released introducing the session today on behalf of the ACIP COVID-19 vaccines work group. Next slide, please. As you can see, daily cases is on the y-axis and time is on the x-axis. This graphic almost doesn't need to be described because it's so visually striking, but I just want to highlight the fact that there's in the range of 490,000 daily cases in the U.S. at the present time, and a total over the course of the pandemic of more than 56 million cases. Next slide, please. So there are several FDA updates. Dr. Cohn made reference to these. We may also hear directly from Dr. Marks about these, but let me just highlight a few. So there's been updates with respect to Pfizer-BioNTech COVID-19 vaccine and boosting. On February 3rd of 2022, the FDA updated the EUA fact sheet for Pfizer-BioNTech COVID-19 vaccine in several ways. Here are the updates. One was to expand the use of a booster dose to include use in individuals 12 through 15 years of age. This will be the primary area of focus of today's discussion, although we will also be focusing or discussing other things and a broader overview of safety, et cetera. There have been other updates from the FDA, including allowing the use of a third primary dose for certain immunocompromised children 5 through 11 years of age. In addition, included in the recent FDA update was a shortening of the time between completion of primary vaccination with the Pfizer-BioNTech COVID-19 vaccine and a booster dose. That interval previously was 6 months, now it is 5 months. And in this, there were memoranda filed for Moderna and Janssen to allow those to be used as booster doses. This is heterologous if it's after a completion of a Pfizer-BioNTech primary series 5 months later. And this obviously applies based on product received and based on those who are eligible otherwise for a booster. Next slide, please. These were decision memos that were announced January 4th, and I will read these. For moderately to severely immunocompromised children 5 through 11 years of age, they can receive an additional primary, meaning a third Pfizer-BioNTech COVID-19 vaccine dose at least 28 days after completion of doses 1 and 2 of the primary series. Again, this is an additional dose, moderately to severely immunocompromised children 5 to 11. In addition, those 18 and older can receive a single homologous Pfizer-BioNTech COVID-19 vaccine booster dose 5 months after completion of the primary series of a Pfizer-BioNTech vaccine. However, the interval for a booster after Moderna and Janssen did not change. So if someone received a Moderna primary series, then they can receive a booster 6 months after completion. If they received a Janssen first dose, they can receive a booster 2 months after completion of their primary series. And then in addition, for those 16 and 17-year-olds who received a Pfizer-BioNTech primary series, they can receive a booster 5 months later. Next slide, please. So to discuss the recent activity of the COVID-19 vaccines work group, in January of 2022, which basically just means yesterday, there was a combined call with the ACIP COVID-19 vaccines work group and the vaccine safety technical work group, which is otherwise known as VAST. And the groups together reviewed updated COVID-19 vaccine safety data and discussed updates to the booster dose vaccine policy. Next slide, please. So here's the agenda for today. We'll first hear from Dr. Su at the CDC. He will review updates to the COVID-19 vaccine safety data from VAERS. Then we'll hear from Dr. House at the CDC, who will review updates to COVID-19 vaccine safety from VSafe. And then we'll hear from Dr. Klein, who's from Kaiser Permanente, Northern California. She will review updates to COVID-19 vaccine safety from the Vaccine Safety Data Link. After that, we'll have a break. After the break, we'll have public comment. And then after public comment, we will hear about updates to clinical considerations from Dr. Twentyman from the CDC. Then we will hear from Dr. Oliver from the CDC, who will review updates to the evidence to recommendations framework. And then we will have a discussion of Pfizer-BioNTech COVID-19 vaccine booster doses in adolescents, 12 to 15 years of age. Discussion will follow, after which we will have a vote on the use of booster doses in that age. Next slide, please. would like to sincerely thank the ACIP work group members, including, this is the COVID-19 vaccines work group, including ACIP members, ex officio members, liaisons, consultants, and the outstanding leadership of Dr. Oliver. Next slide, please. And then I'd also like to take a moment to thank the many colleagues at the CDC who contributed their time and expertise to the presentations we hear today. I think that something the listening audience may not be aware of is that it takes literally hundreds of hours to prepare materials for ACIP meetings. And this isn't simply preparing slides, it's also gathering data, analyzing data, interpreting data, integrating information from multiple sources. And so I suspect that many of the folks on this slide were long overdue for vacation and had vacation planned last week, but instead spent long hours preparing the materials for the meeting today. So, for the folks on this slide, we ask a lot of you and we greatly appreciate your service to the nation's public health. Next slide, please. So thanks, and I turn it back to you, Dr. Lee.
Thank you, Dr. Bailey, and we can't emphasize enough how appreciative we are that our CDC colleagues have been working nonstop and really have not had the holiday break that many of us were fortunate to at least have had. So thank you. I want to emphasize that over and over. Before we get started, there's a couple of announcements. First, I want to call on ACIP member Ms. McNally to state her name, affiliation, and whether she has any conflicts of interest.
Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts. Thank you.
Thank you, Ms. McNally, and thank you for making yourself available. And second, I'm going to actually turn it back over to the room at CDC, perhaps Dr. Oliver or Dr. Wharton, and ask if you can introduce two additional attendees and introduce them for to the committee and to the public.
Thank you so much, Dr. Lee. This is Dr. Oliver. First, we're happy to say that Dr. Marks from FDA has been able to join us, and so he can give a few comments from FDA about recent action this week. Dr. Marks?
Sure. Thanks very much for having me. And I actually would just echo thanks to all the CDC colleagues who have been working through the vacation period to keep these actions moving. So I will very briefly say something about the three actions, mainly focusing at the end on the 12 to 15-year-olds. The recent surge in COVID-19 cases, first provoked by Delta and then with Omicron on top of it, has led us to look carefully at any actions that we could take in order to enhance the protection of the population through vaccination. With that, we looked at data that had been provided to us by various companies. In this case, for the Pfizer vaccine, we were aware of the data showing that a booster could be given at 5 months after the completion of the primary series safely, and they had in 4.7 million individuals studied in a large real-world evidence study, good evidence that seemed to be effective, and in 4.1 million individuals for whom they had safety data who received the booster, again, good safety data. So in the action to bring down the booster interval from 6 months to 5 months made evidence-based sense, particularly given that we seem to understand now that protection against the Omicron variant in particular may require higher titers of antibodies, and that might be achieved sooner by allowing people to be boosted sooner. The second action of enlarging the population that would be eligible for a third dose of the primary series to include the 5 to 11 age range was really a straightforward one based on a risk-benefit consideration and the potential need in that population of immunosuppressed individuals, those who might have received organ transplants or an equivalent. We had previously brought it down to the 12 to 15 age range, and this essentially was a move based on looking at the safety data that we had to complete that and allow 5 to 11-year-olds who were either immunocompromised or had getting immunosuppressive medicines because of transplant to be able to get a third vaccine, knowing full well that that still may not restore the ability of these vaccines to provide a full level of protection, but it was something else to be done. The final action is the 12 to 15-year-old boosters, extending boosters to at 5 months to the 12 to 15-year-old population. That was based on a combination of looking at the risk modeling that we had previously done as we evaluated the vaccine use in the 12 to 15 age population, and actually through the pediatric age spectrum, as well as looking at the data that came from Israel on over 6,000 children who had received ages or adolescents who had received the vaccine as a booster dose at 5 months. And given that there did not appear to be new safety concerns, and then again, given the current surge in cases, it was felt to be a reasonable action to extend the potential use of a booster dose down into this age range. One final comment on this is that from prior work that we had done and that has emerged from other sources as well, it appears that the risk of myocarditis, which is higher anyway in males, appears to peak at age 16 and 17. And so I think you'll see some data later on today that may comport with that. So that was the sum of our actions. Thanks very much.
Thank you, Dr. Marks. Dr. Oliver?
Thank you so much. We have one other person before we get with our scheduled agenda today. I want to introduce Dr. Alroy with the Israel, who's been able to join. We're incredibly privileged to have them join us today. We want to thank so much. We acknowledge that it is considerably later there, and so they're joining us late into their evening. They've been incredible partners as we try to balance this, review data, and learn from others' experience. And so I want to thank them very much for being willing to come on today's ACIP meeting and share their experience. Dr. Alroy, feel free to, you should be able to be a co-host and share your screen if you want to show slides. Otherwise, we can pull them up here. Thanks.
Thank you so much. Hopefully you can hear me.
We can, and we can see your slides. Thanks.
All right. So I'm happy to join you. Happy New Year to everyone. I was asked to introduce or to describe the results that we have so far for the 12 to 15 years old booster vaccination campaign, and I'm happy, obviously, to share them. So why giving a booster dose? Because as in the adults, we have been seeing waning of immunity in that age group too. I'm showing you the data from the last week where the age group 12 to 15 years old is the highest group, leading group in confirmed infection, as you see in this pinkish red line going up. And so their confirmed infections are going up very steeply. Our vaccine coverage before this current wave, we started with a vaccination of the 12 to 15 years old in the middle of June, which was our fourth wave, in the beginning of our fourth wave. And as you see in the blue line, we got to 65% coverage.
I'm sorry to interrupt, Dr. Alroy. We just see the title slide right now. Is it possible to move to the next couple of slides?
Sorry, I'm moving in my computer, but it's obviously not doing the same for you. So thanks for letting me know. If I'm moving like this, can you see?
Yes, we can. Thank you.
Okay, so I'll just keep it like that. So this is the graph that is showing confirmed infection of the past week, and we see this line in red, kind of pinkish, which is the 12 to 15, and this is the leading group, age group in confirmed confirmed infections. So they are seeing a really steep rise in their infection rates. Hopefully you can see the next slide now, if I move like that. And
Yes, we can. Thank you.
Yes, we can see it.
Kids, it has been usually Pfizer vaccine. So the passive surveillance is basically reports from medical staff in community and hospitals. Once they report to us and we confirm the vaccine status, which we have in our Ministry of Health, we're completing data from our health maintenance organizations and the hospitals, and we are reviewing the medical files to verify medical background and differential diagnosis. When something that is considered serious adverse report is reported to us, it is reviewed by a designated medical committee that is trying to link the adverse event to the vaccination. And then obviously there's data processing and statistical analysis, and we obviously present the data anonymously. For the active surveillance, which we started conducting in about February, we started that when we saw a signal after Pfizer vaccine vaccinations of myocarditis, and since then we have been conducting active surveillance routine. We are actually contacting all hospitals. In Israel, myocarditis is a diagnosis that is requiring hospitalization. So probably most of the cases are in the hospital. We're contacting them on a weekly basis, and based on ICD-9 codes, they're getting all the data, obviously doing QA and data confirmation, completing the medical history as needed, and then all those cases are reviewed by a designated medical committee consisting of cardiologists and rheumatologists to try to figure out the story. And actually, it's all myocarditis cases. It's not just those after vaccination. So the booster safety data is very reassuring by both of those different surveillance methods. We have given over 41,000 doses, and in our follow-up, we have only 2 cases of myocarditis, both in males. One 13-year-old male, 3 days following his booster dose. He had also a medical history of pericarditis in 2019. And a 15-year-old male, 4 days following the booster dose. Both of them did not have any compromise, any cardiogenic compromise. They were both released after a few days in the hospital in good conditions. Ejection fraction was completely normal, no arrhythmia, nothing concerning. So those are the 2 cases that we had. And in addition to that, in our passive surveillance, we were reported of 2 non-serious reports, restrictions of movement and a headache. So really minimal safety signals here. And the preliminary results of the impact, and so what we saw is this is the rate, the confirmed infection rate for 100,000 risk days for age groups 12 to 15. So you're seeing the unvaccinated have obviously a very high rate of infection. After the booster, 1 to 2 months after the second dose, you're seeing a significant drop in confirmed cases, and a waning effect that happens which basically after 5 to 6 months, those kids are having the same rate of infection as the unvaccinated group. But once they're getting the booster, about 7 to 10 days after, we're seeing a significant drop in infection rates in that group. So that's the results that we have so far from Israel, and I'm happy to answer questions if you want. I can only stay with you for a few more minutes, and I have to go to other meetings, but I'm happy to answer anything at this time.
Thank you, Dr. Elroy. I want to thank both Dr. Marks and the entire FDA for continuing to be responsive to this public health emergency, along with our CDC colleagues. And Dr. Elroy, just really appreciate this global collaboration and response that is so sorely needed. We are going to offer this presentation open for questions, since you did offer a few minutes of your time. So I will ask if there are any members who have questions first, and then we'll open it up to liaisons and other members. I see Dr. Kimberlin is quick on the hand, so go ahead, Dr. Kimberlin.
David Kimberlin, AAP Redbook. Can you inform us a little bit more on the impact of boosters on severe disease, hospitalizations, and not cases, but actually, the end extreme of what we're really trying to prevent here?
So we don't have a lot of 12 to 15 years old severe disease during the acute phase, but we did have cases of PINs in that age group, and mostly among the unvaccinated group. So we were seeing, and I can pull up the numbers, but we were seeing several, like 40, 50, 70 cases of PINs in that age group, but all of them were unvaccinated individuals. And in addition to that, we also had in that age group 2 fatalities of unvaccinated 12 to 15 years old, 1 female and 1 male, because of PINs. So we are not seeing a lot of hospitalization in the acute phase in a severe and critical conditions, but we have seen severe disease in PINs conditions, and it's roughly every 1 to 2,500 cases, all in all in children, not just in 12 to 15 years old. So we are concerned from that standpoint.
Thank you, Dr. Elroy. Are there any additional questions that our colleagues have? One for you, Dr. Elroy. During the period of time when you've looked at the efficacy of the vaccine in terms of the rates of infection following booster compared to other intervals post the 2-dose series, what was a major circulating variant during that time?
So in our 4th wave, the major variant was Delta. Now we are seeing a combination of Delta that was starting to come down from the 4th wave, which we got to about 10,000 confirmed cases a day. We got to roughly 500 a day, and then before it was completely gone, Omicron entered. And so we now have a combination of mostly Omicron, but also Delta. And so the confirmed infection right now that I showed you the results, the impact of the booster is during a period of time when we have both Delta and Omicron.
Thank you so much. Dr. Long?
Yes, it's a question for Dr. Peter Marks. In the decision to provide a 3rd dose for 5 to 11-year-olds with immunocompromising conditions, did you have any antibody data on any children of that age group to understand their responses after 2 doses, or was it a decision based on supposition?
Yeah, no, thanks for that question. This was based on essentially the way we do immunobridging to older individuals, and so the analogy here was in that population getting a lower dose of vaccine, they would have a similar response to the 12, 15-year-olds who would have a similar response to the adults in terms of not having a good response to this. That we would also just say that we expect that many of these children will be treated at transplant centers where they may be using either quantitative or semi-quantitative assays to assess antibody levels, because that's the only way one will actually know that somebody has actually responded after a third dose. So we suspect that there will be some data that will come from that as use goes on. Over.
Thank you. I just want to do a last call for Dr. Alroy because I want to just recognize that she has generously donated her time to us and to another meeting. Okay, thank you so much, Dr. Alroy and Dr. Marks, for making yourselves available to the committee and to the public to share your information, and we really appreciate it. We will, if there are additional questions, please just let us know, and we will try and follow up afterwards. But we do need to move on to the next part of the meeting. Thank you again. So we'll move on to Dr. John Su, who will present updates on the COVID-19 vaccine safety updates from the VAERS team. Dr. Su.
Good afternoon. I hope everybody can hear me okay. Go to the next slide, please. Excellent. And the next slide, please. So I'll just be covering some data on primary series after Pfizer-BioNTech's mRNA vaccine for children and adolescents ages 5 to 11 and 12 to 15 years. Really, the 5 to 11-year-old data is just sort of an update on existing data. We'll also be sharing data to VAERS after Pfizer-BioNTech's booster vaccination in adolescents and adults aged 16 to 24 years. Next slide, please. So just a reminder that VAERS is the nation's passive surveillance system, and it's designed to be an early warning system. Next slide, please. And so because it's a passive surveillance system, VAERS is quite sensitive. And so some of its strengths include rapidly detecting potential safety concerns, as well as previously unreported adverse events. However, one key limitation of a passive surveillance system is the fact that you can have incomplete data, but perhaps most notably, you generally cannot use VAERS data to determine whether or not the vaccine caused the reported adverse event. And that's just something we try to emphasize. Next slide, please. So moving on to data on children and adolescents ages 5 through 11 and 12 to 15 years. Next slide, please. So on this slide, we show by age group just some descriptive data, including on the right, median age, breakdown by sex, by serious status, as well as total reports and doses administered. And really, I think the take home from these data is that for either age group, most reports, better than 92%, were non-serious, and that distribution by sex is quite similar. Next slide, please. So here we show the race and ethnicity data for these different age groups, with race ethnicity on the left, followed by age groups on the right. And really, this kind of reflects some of the limitations of VAERS in that one of the most frequently reported data are those folks who did not report any data, otherwise of white, non-Hispanic race and ethnicity. Next slide, please. So here we're showing the most frequently reported adverse events to VAERS among children and adolescents ages 12 to 15 years. On the left, we show the 8 most frequent adverse events reported among non-serious reports, and on the right, those that are serious. And these typically reflect vaccination error as well as previously observed adverse events, as well as workup for myocarditis and multi-system inflammatory syndrome in children. And you may note that there are some results over here that reflect normal findings, and I'll walk through a hypothetical on the next slide just to illustrate how that can happen. Next slide, please. So this slide presents data on the most frequently reported adverse events after Pfizer-BioNTech's vaccine in children 5 to 11 years of age. Again, on the left, the most frequently reported adverse events for non-serious reports, and on the right side for serious reports. And again, these tend to reflect, you can see for non-serious reports, a lot of vaccination error. And I will add that when people report vaccination errors, they often explicitly state that no adverse event occurred, and that's why you can see that as the number one adverse event, if you will, being reported. If you go past the top 8, so if you look at, say, 9, 10, and so forth, you see a continuation of adverse events that have been previously observed after Pfizer-BioNTech's vaccine, things like headache, things like fatigue, pain at the injection site, that sort of thing. And just to walk through that hypothetical I was talking about, let's say, for example, that you have a patient who, after vaccination, 2 days later, develops chest pain bad enough to cause vomiting. They get seen in the emergency room, and the physician orders a battery of tests, perhaps serologies to look at previous exposure to SARS-CoV-2, maybe a troponin, maybe because of concern for MIS-C, maybe ordering a C-reactive protein, as well as some diagnostic imaging such as echocardiography, perhaps an EKG. And so we can see that in some of that testing, you may end up with normal results. But the medical coder, when assigning standardized codes to these reports, might still include them in the report itself. And that's why on their serious reports, for example, we can see things like a normal echocardiogram or a negative SARS-CoV-2 test, because that reflects what some of the diagnostic workup was performed for that given patient. So just so you can have a better understanding of how we can end up with adverse events that don't really necessarily indicate a negative outcome. Next slide, please. On this slide, we show reports of myocarditis among children and adolescents aged 12 to 15 years. We start with 317 preliminary reports of myocarditis in children these ages, and the flow diagram on the right shows how we ultimately adjudicated 265 reports that met the case definition of myocarditis. Median age for these reports was 14 years, and much of the data here reflects what we've seen in older age groups, with a median time to onset of 2 days, most reports being after dose 2, and most being after males. There were some 251 patients known to be hospitalized. Most of them were discharged home. There were 224 patients for whom we had known outcomes, and most of these folks had recovered from their symptoms at time of report. There was a small proportion for whom were not fully recovered at time of report, but had reported improving or resolved symptoms, but remained on physical restrictions, and some remain under investigation. And just for context, during the time period here, we had 18.7 million doses administered to this population. Next slide, please. This slide shows the same data for children ages 5 to 11 years. There were 16 preliminary reports of myocarditis identified, 12 of which were verified to meet case definition. The median age was 10 years, and like for 12 to 15 years, much of these data reflect what we've seen with older age groups, with the median time to onset of 2 days, most reports being after dose 2, again, most being after males. Of these 12 reported cases, all patients were discharged home. 8 were recovered from their symptoms at time to report. There's another 4 who are still recovering at time to report, much like what we saw in the previous slide. One thing I'll add is you might recall that for non-serious reports, there was a large proportion of vaccine errors being reported. I just want to point out that of these 12 reports of myocarditis, none reported a vaccination error. And again, for context, 8.7 roughly million doses of vaccine had been administered to this population. Next slide, please. So on this slide, we show estimated reporting rates of myocarditis per 1 million doses administered during the 7-day risk period after vaccination. And so on the left side, we show by age group, and we include 16 to 17-year-olds here just as a point of reference. And then on the right side, broken down by sex, and then by dose number, the estimated reporting rate. There were about 37.8 million doses of dose 1 or dose 2 of vaccine administered. And for reference, the background incidence during this risk period is anywhere from 0.2 to 1.9 per 1 million person 7-day risk period. And so the values here that exceed that range are highlighted in peach. And what we see over here is that there is an elevated rate among males after dose 1 for ages 12 to 15 and 16 to 17 years, and after dose 2 for all 3 age groups reported. But I will note that there's a very large difference between 5 to 11 and the other age groups. We also see elevated rates among females after dose 2 for ages 12 to 15 and 16 to 17-year-olds. One thing that I'll add is that we are very early in the vaccinations for children 5 to 11 years of age, and so we anticipate that there may be some reporting biases at play, and we expect these numbers to vary some. And as the data mature, we'll see hopefully more stable rates later down the road. Next slide, please. So to briefly sum up, since authorization, there have been 8.7 million doses of Pfizer and BioNTech's COVID-19 vaccine administered to children ages 5 to 11 years, and 18.7 million doses administered to children and adolescents 12 to 15 years of age. Regardless of age group, most reports were non-serious. The most frequently reported adverse events were known and well-characterized adverse events. We do have reported myocarditis among children ages 5 to 11 years. Most were after males and mostly after dose 2, consistent with older age groups. And reporting rates for males aged 5 to 11 years were substantially lower than for males of older age groups. And CDC will be continuing to monitor vaccine safety among these age groups. Next slide, please. So shifting gears and talking about booster vaccination among persons 16 to 24 years of age. Next slide, please. And again, these are after Pfizer-BioNTech's vaccine. We can see here some general descriptive information on the left broken down by age group, and on the right by sex, serious status, total reports, doses administered. And again, I think the take home from these data is that most reports, better than 95%, were non-serious. Next slide, please. Here we show some of the race and ethnicity data for these age groups. Boosters were only recently authorized for 16 to 17-year-olds, so you can see we really don't have much data there. And for 18 to 24-year-olds, the data are quite consistent with what's been reported previously. Next slide, please. Here we report the most frequently reported adverse events, and because we are so early in vaccinations among 16 to 17-year-olds, we just present the aggregated count of serious and non-serious for the entire 16 to 24-year-old age group. On the left, the most frequently reported adverse events among non-serious reports, and on the right for serious reports. And again, these tend to reflect previously observed adverse events as well as workups for myocarditis. Next slide, please. Among these patients, we did identify 13 preliminary reports of myocarditis. 4 met case definition. Just to provide the brief descriptives of the preliminary reports of myocarditis, the median age is 21 years. Median time onset was 1 day. Most were males. There were, of the 4 reports that met case definition, 2 reports among males ages 16 to 17 years, 2 reports among ages 18 to 24 years. 1 was male, 1 was female. All reported patients were recovered at the time of report, and during this time period, we've administered roughly 1 million doses of vaccine. We didn't provide any reporting rates. We are very early in the report or in the vaccination campaign using these boosters, and as the data mature, we might be able to offer this down the road. Next slide, please. So just to sum the data on booster vaccination among ages 16 to 24 years, there have been about 47,000 persons ages 16 to 17 years who received a booster dose, and about 930,000 persons ages 18 to 24 years who received a vaccine booster dose. Most reports were non-serious. Again, the most frequently reported adverse events had largely been known and well characterized. We had 13 preliminary reports of myocarditis, 4 of which met case definition. All 4 reported patients had recovered from symptoms at time of report, and the characteristics do seem to be consistent with what we've seen after dose 1 and dose 2. Again, CDC will continue to monitor the safety of vaccine booster doses. Next slide, please. I just wanted to thank the many people who made these data possible, including our state and local partners. Next slide, please. And we have time. I'll be happy to answer any questions. Thank you very much.
Thank you, Dr. Su. We will open this presentation for questions now. Dr. Paley?
Dr. Su, thank you very much for sharing what is available in the VAERS database. The question I wanted to ask you, it seemed to be that you were saying that these children have resolved or are resolving. And so I wanted to confirm, have you identified any deaths from myocarditis after the vaccine that met definition? Thank you.
Sure. There was one patient who had died afterwards, and there was myocarditis identified on postmortem. What is unclear is what role the myocarditis played in the patient's demise. That report remains under active investigation. So, we don't know at this time what role vaccination, or at least what role myocarditis played in that patient's death.
Dr. Daly.
Great, thanks so much. Thanks, Dr. Su, for that presentation. I have a comment and then a question. The comment is that I appreciate seeing the data on 5 to 11-year-olds, and I think there are parents out there who have concerns, including concerns about myocarditis, and maybe they're waiting to see what the safety profile looks like. So I think the fact that, I know we're early, but the fact that it appears that the rate of myocarditis is quite a bit less in this age group, I think is going to be reassuring to parents who'd like to vaccinate but are sitting on the fence. And then my question is, could you tell us about long-term follow-up plans for individuals diagnosed with post-vaccination myocarditis? Over.
Hey, thanks for that question, Dr. Daly. So currently we have a group, and what we've done is to identify those patients who were identified as meeting the case definition, and we have that group following up on these patients for those folks who are 90 or more days out from their initial presentation with myocarditis, and just reaching out to them and their providers just to get a sense of how they're doing now. We've gone through the initial follow-up with some of these patients, and I believe that we are currently analyzing those data and plan to publish those in the near future, hopefully.
Dr. Long.
Yes, it's a comment to Dr. Daly and also a comment for Dr. Su. It seems to me that we should not conclude anything about reduced occurrence of myopericarditis in the young age group at this point, at the 5 to 11-year-olds, since we know that it is more pronounced on the second dose, and we know from the timing of the recommendations that all of those second doses, I calculate it, have to have occurred in December. And in my own family, getting them as soon as they could, non-availability, et cetera, the second dose only occurred around Christmas Day. So since it took us 4, 5, 6, 7, 8 months to get the numbers right about myopericarditis following the second dose, where originally we thought maybe it was a couple in a million and then down to 400, 500,000, and now it looks like it's about 1 in 14,000 male second doses. So I can see you're concluding for those parents waiting that there is no worrisome signal, but I think it's much too early to say, and I know it's going to be said later today, and I think we'll actually see when the doses were given, that those 8 million doses are not mainly the doses that are most prone to cause mild pericarditis, so that we should be very cautious and not try to overcompensate for concern about this age group and reassuring people. Thank you.
Thank you, Dr. Long. Dr. Daly?
Yeah, Dr. Long, thanks for that, and that's a great point to me, and I don't disagree. I think it's early, but this wasn't overly alarming, and I think we did get evidence about myocarditis in other age groups sooner than 8 months, but I fully recognize we need to see what happens after dose 2, and there are limitations to the VAERS system as well, so we need to be cautious, but I still feel like it's valuable to look at the current state of what we know about 5 to 11-year-olds. Thank you.
Thank you. Are there any other clarifying questions about this presentation that people would like to ask? All right, I think we will move on. Thank you, Dr. Sue, for your presentation. We'll move on to Dr. Ann House, who will present updates on COVID-19 vaccine safety from the VSafe team. And as she's pulling up her slides, I will just state that Dr. Oliver in her presentation will have a comment from VAST in terms of the interpretation of the totality of the safety data that was reviewed this week. Thank you.
Thank you. Can you hear me?
Yes, we can.
Okay, so today I'll be presenting an update on safety monitoring for COVID-19 vaccine among children and young adults in VSafe. Next slide. VSafe is a voluntary safety surveillance system. It allows a parent or guardian to enroll their child after any dose of COVID-19 vaccine, and children less than 16 years of age must be enrolled by a parent or guardian. VSafe allows existing participants to report receiving a booster dose of COVID-19 and new participants to enter information about all doses received and complete health surveys on their most recent dose. VSafe health surveys are sent daily during the week following each dose of vaccine and include questions about local injection site and systemic reactions, as well as health impacts, including inability to perform normal daily activities, inability to attend school or work, and receipt of medical care. Additional health surveys are sent weekly through 6 weeks after vaccination and at 3, 6, and 12 months after vaccination. Next slide. As of December 19, 2021, Pfizer-BioNTech vaccination had been reported for over 115,000 VSafe participants aged 5 to 15 years. Approximately half were female, 37% were aged 5 to 11 years, and 63% aged 12 to 15 years. 78% classified as non-Hispanic, and 68% as white. Next slide, please. This figure shows the frequency of reactions and health impact events reported at least once during days 0 through 7 after Pfizer-BioNTech vaccination by dose and age group. Children aged 5 to 11 years are represented in blue, and children aged 12 to 15 years in orange. In general, reactions and health impacts were more frequently reported following dose 2 than dose 1, and more frequently reported for children aged 12 to 15 years than children aged 5 to 11 years. Next slide. This figure shows the frequency of any systemic reaction reported for children aged 5 to 11 years and 12 to 15 years, at least once during days 0 through 7 after dose 2 of Pfizer-BioNTech vaccine by days since vaccination. On the x-axis is days since vaccination. And again, children aged 5 to 11 are shown in blue and children aged 12 to 15 years in orange. Reactions were transient and most frequently reported the day following vaccination for both age groups. Next slide. This figure shows the frequency of the top 5 reactions reported for children aged 5 to 11 years and 12 to 15 years, at least once during days 0 through 7 after dose 2, Pfizer-BioNTech vaccine. Injection site pain, fatigue, headache, myalgia, and chills were all frequently reported in the week following dose 2 for both age groups, and were more frequently reported for children aged 12 to 15 years than children aged 5 to 11 years. Next slide. Now I'm going to shift gears a little bit and present booster data for adolescents and young adults. As of December 19, 2021, over 7,000 V-Safe participants aged 16 to 24 years had reported a homologous Pfizer-BioNTech booster dose. Approximately 72% were female, 7% were aged 16 to 17 years, and 93% were aged 18 to 24 years. 84% identified as non-Hispanic, and 74% as white. Next slide. This figure shows reactions and health impact events reported at least once during days 0 through 7 after Pfizer-BioNTech vaccination by dose. The odds of reporting an event following dose 2 and booster dose were compared. Those that were statistically significant are indicated by an asterisk. Dose 1 is shown in yellow, dose 2 in blue, and booster dose in green. Injection site reactions and systemic reactions, as well as health impacts, including inability to perform daily activities and inability to work or attend school, were all less frequent following booster dose than dose 2. Receipt of medical care was reported more frequently following booster dose. However, the difference is very small. Next slide. This figure shows the frequency of any systemic reaction reported at least once during days 0 to 7 after each dose of 5 days since vaccination. Reactions were transient and most frequently reported the day following vaccination for each dose. Next slide. This figure shows the frequency of the top 5 reactions reported at least once during days 0 through 7 after each dose of Pfizer-BioNTech vaccine by dose. Again, pain, fatigue, headache, myalgia, and chills were frequently reported and were less common after booster dose than dose 2. Next slide.
Yeah, I'm in a.
Dr. Hogue, I think.
I apologize.
Next slide, please. Sorry, could I have the next slide? These data are subject to a couple of limitations. First, V-Safe is a voluntary system, and as such is likely not completely representative of the vaccinated U.S. population. Second, booster doses had only recently been authorized for age 16 and 17 years at the time of this analysis, and the data were somewhat limited to describe reactions for this age group. Next slide. To summarize, Pfizer-BioNTech vaccination has been reported for over 115,000 V-Safe participants aged 5 to 15 years. Reactions were generally mild to moderate and frequently reported the day after vaccination. Reactions were more frequently reported after dose 2 than dose 1, and participants aged 5 to 11 years reported reactions more frequent or less frequently than participants aged 12 to 15 years. However, children aged 5 to 11 years do receive a smaller dosage of vaccine than children aged 12 to 15 years. In addition, over 7,000 V-Safe participants aged 16 to 24 years reported a homologous Pfizer-BioNTech booster dose. Reactions were generally mild to moderate and most frequently reported the day after vaccination. Also, reactions were less frequently reported after booster dose than dose 2. Next slide. I'd like to acknowledge the many people who made this analysis possible, including those who participate in V-Safe. Next slide. Next slide. Thank you. I'll take any questions.
Thank you so much, Dr. House. This presentation is now open for questions. And while we're waiting for hands to be raised, I do want to make a quick statement to the public that VSafe has been an incredibly helpful resource during the COVID-19 pandemic to monitor vaccine safety, and would continue to encourage your patients, your family members, your colleagues to report into VSafe. I think it is incredibly helpful for us to have that real-time information and tracking, and particularly for our pediatric patients. I think although attention has waned a little bit, I still think that this is an important system for us to continue to support and make sure that everyone is able to share their vaccine safety stories through VSafe and through theirs. Any questions for Dr. House? I don't see any hands raised. Are there any questions from our liaison members for Dr. House on VSafe? Okay, we will then move on to oh, sorry, go ahead, Dr. Duchin, just in time.
Thank you. I was slow on the button there, the raise hand button. Dr. House, thank you. Just a quick question. Can you comment on the preponderance of female respondents in the VSafe data that you presented?
Thank you for that question. I think you're probably referring to the booster doses in persons aged 16 to 24 years, where we had about 70% of participants who were female. This is more exaggerated than for primary series, and that might just be a reflection of females seeking out booster doses compared to males. But we will definitely look into that. And I will note that for our modeling, we do control for sex as well as race ethnicity.
Thank you so much for doing this important work.
Thank you.
Thank you. I don't see any additional hands raised, so we will move on to Dr. Nikki Klein, who will present updates on COVID-19 vaccine safety from the Vaccine Safety Data Link team. Dr.
Great. Thank you very much. I'm delighted to be here today, and good morning or afternoon to you. So today I'll be presenting on the Vaccine Safety Data Link rapid cycle analysis on uptake and safety in both 5 and 11-year-olds and mostly 12 to 17-year-olds. Next slide, please. So the Vaccine Safety Data Link, for those of you who are not familiar, is a collaboration between the CDC and 9 integrated healthcare organizations that include full electronic data and medical record information on more than 12.5 million of its members. Next slide. So the VSD's rapid cycle analysis, or RCA, the aims of the study have been to monitor the safety of COVID-19 vaccines weekly using pre-specified outcomes of interest among VSD members, and also to describe the uptake of COVID-19 vaccines over time among VSD members. We've been surveilling this and reporting since December 2020. Next slide, please. So here are the outcomes that we are monitoring. These have been in place since we've started the monitoring, and as you can see listed there, they've been applied to the 12 years and over population that I have reported on previously, as well as this is the same list of outcomes that we are going to monitor, and then we have started monitoring for the 5 to 11-year-olds, which I will discuss briefly at the end of the presentation. Now, for the 12 to 17-year-olds, you can see highlighted as the myocarditis, pericarditis cases, which will really be the focus of the rest of my talk for the 12 to 17-year-olds right now. Next slide. So a brief word about our myocarditis and pericarditis outcome. So here, these are the electronic codes that we've used to identify the cases. And on the left, these have been the codes that we have been using. You can see listed, and this was originally based on input that we received in consultation with cardiologists when we were designing the study well over a year ago. However, since that time, and since we've been monitoring it much more closely, we have actually recently revised our ICD code list based on feedback from other investigators and sites in the VSD with regard to how the codes are being actually used. And so we've, in addition to the 4 in black, you can see listed, we've added the additional 2 codes in red. Again, these are just in inpatient setting and emergency department settings. For those of you who are paying close attention, you may note that there's an increase in the number of cases that would be a little bit more than incremental based on these, and they are due to the addition of these additional codes right here. Next slide. So for our analytic strategy for our RCA, the primary analysis, the number of outcomes observed in the risk interval, which has been 1 to 21 days after COVID-19 vaccination, were compared to the number expected. And expected were derived from what we've been calling the vaccinated concurrent comparators, who are in a comparison intervals on days 22 to 42 after COVID-19 vaccination. So on each day that an outcome occurs, vaccinees who are in their risk interval will compare to similar vaccinees who are concurrently in the comparison interval. And the comparisons were adjusted for age group, sex, race, ethnicity, VSD site, as well as calendar date. Next slide. So this is a figure I've shown previously, and what this is a demonstration of the analytic strategy I just described. And this shows a representative vaccinee with myocarditis who had myocarditis on June 3rd. So they were in their risk interval during 1 to 21 days after vaccination because they were vaccinated on May 30th. So on June 3rd, we found a similar comparator who are in their comparison interval on that is 22 to 42 days after vaccination. And by a similar comparator, we mean that they were in the same age group and at the same sex, race, and at the same VSD site. And these are the analyses that I will be showing you in the subsequently slides. Next slide. So here is our vaccine uptake and analyses among 12 to 17-year-olds, and this data is as of December 25th, 2021. Next slide, please. So here you can see this is the Pfizer vaccine totals by week in adolescent age groups. And now, if you look at the x-axis, you can see this represents just about a year of time. So you can see that those in blue, the dark blue and light blue, represent the 12 to 15-year-olds, and then in orange is the 16 to 17-year-olds. And you can see that uptake within these different populations is fairly well reflected by the date on when the emergency use authorization was granted for each of these different age groups. Next slide. So regarding the myocarditis and pericarditis, we chart review all cases that occur under individuals under the age of 40 from 39 and under, review all of them. Today I'll just be discussing those for 12 to 17-year-olds, but we do review all cases under 39 and younger. The data today reflects the chart was completed through December 30th, 2021 for 53 out of the 75 cases amongst 12 to 17-year-olds. And these cases were identified anytime after either dose of a Pfizer COVID-19 vaccination. So following initial chart review, all cases are adjudicated by an infectious disease clinician and or a cardiologist, and that is to confirm that the cases were incident following vaccination and they met CDC case definition. So with adjudication, there were 47 out of the 53, or 89%, were adjudicated as a confirmed case. As you can see, the 43 were amongst the 12 to 17-year-olds occurred 0 to 21 days after vaccination, and 39 with onset 0 to 7 days after vaccination. Slide, please. So these are the characteristics from the validated or chart reviewed cases for aged 12 to 17-year-olds in the 21 days after vaccination. This represents the 43 cases. And so what you can see is that there are 29 12 to 15-year-olds and 14 16 to 17-year-olds, and actually doing very rough estimates, the rates were approximately the same for both the two age groups when you take into account the number of vaccines given in each of the two age groups. For all these cases, the symptom onset had a median of 2 days. You can see the range 0 to 20 days, and for the diagnosis, just over half were acute myocarditis, with most of the rest being myopericarditis and just 2 cases being diagnosed as acute pericarditis. Next slide, please. So with the exception of 4 cases, all the cases were admitted to the hospital. 65% were just in the hospital, with the remaining 26% admitted to the ICU. I think it's 11 in the ICU. I will talk a little bit more about it in a minute. The median length of stay for these cases was 2 days, and you can see listed that most were between 1 and 3 days, as you can see here, with a few more at days, 4 days and longer. Next slide. Oh, I'm sorry, one more thing is that they're all discharged home. All cases were discharged home. Next slide. So with regard to the cases that were admitted to the ICU for the 12 to 17-year-olds, they ranged in age from 13 to 17 years. They were all men, all males. The race, there are 5 Hispanics, 4 white, 1 black, 1 unknown. They were diagnosed 4 with myocarditis and 7 with myopericarditis. And among those who were admitted to the ICU during the hospitalization, the median length of stay for the entire hospitalization was 5 days. And then finally, the chart notes for 2 of the cases indicated that the ICU admission was preventative. And then there was an additional chart, so a third case, where the chart was noted that the ICU admission was actually unrelated to the myocarditis. Next slide, please. So here's the analysis of these cases amongst 12 to 17-year-olds. Next slide, please. So this represents the vaccinated concurrent comparators, again, with the analytic strategy and the figure I showed you earlier, and focusing on both the 0 to 21 and 0 to 7-day risk interval, which is what we focused on because of our chart reviews. We found that many cases occurred around day 0. So when we look at after those 2 in the 0 to 21 days, you can see a very elevated rate ratio, 15.2, with high significant confidence intervals. And that is even more pronounced after the 0 to 7-day risk interval after dose 2, and you can see the rate ratio over 46, with, again, highly statistically significant confidence intervals. One thing to point out, though, is that the excess cases were 70 cases per million doses, both for after dose 2 for both the 0 to 21 and 0 to 7-day risk interval, which indicates that all the risk is occurring during the 0 to 7 days interval. This is in contrast to the SF cases in the risk after dose 1, which was for 0 to 7 days, 0.3 cases per 1 million doses. Next slide, please. So we've been doing ongoing follow-up chart reviews for our validated cases. And these chart reviews are conducted 3 months after the initial diagnosis to obtain information on the symptoms and diagnostic evaluation of the most recent follow-up visit and the recovery status of the most recent follow-up visit. So as of December 30th, 2021, we've completed reviews for 32 cases among 12 to 17-year-olds that were time eligible in that for follow review, and that's at least 3 months had passed since their initial diagnosis. So of these 32 cases, 24 had at least 1 follow-up visit at least 1 month since the initial encounter. So these 24 are the ones I'll describe the next couple of slides. Next slide, please. So for these 24 cases that had at least one visit 1 month after diagnosis, the time to discharge to the follow-up visit had a median visit of 88.5 days, is the range you can see there. But only 13, or just over half of them, actually had a follow-up visit of at least 3 months since the initial encounter. And then there are also 13 or...
Not too much emphasis on.
There's no new or worsening symptoms noted, or just over half of them. And then the ones who did still report some symptoms, it was 38% had reported chest pain, pressure, discomfort. There's far fewer of these individuals had follow-up diagnostic studies done, with exception of EKG. 75% of these cases, 18 had an EKG completed, and 50% of those were considered abnormal, so 9 of the 18. Next slide. And then in terms of the status of the most recent follow-up visit for these follow-up cases. 11 of these adolescents, 46%, were noted to have no symptoms, medications, or exercise restrictions as of the time of the review, with the remaining still on either symptomatic or still on exercise or physical activity restrictions, and a couple still on medication. Next slide. So turning to the 5 to 11-year-olds, and this will just be a brief update on our vaccine update and primary analysis, and this is from data through December 11th. Next slide. So here's just to show you really just the timing of when our doses were starting to be given within the vaccine safety data link amongst children 5 to 11-year-old. And like we've seen with previous age groups, you can see a large increase in uptake for vaccinations following the emergency use authorization for this age group. Next slide. So for a reminder, for our RCA analysis for our 5 to 11-year-olds, we're using the same methods for children aged 5 to 11 as I showed you and I've discussed for adults and adolescents, and the same outcomes as the list I showed you earlier in this presentation. In the vaccine safety data link, there's about 848,000 children aged 5 to 11 years, and as of December 25th, 431,485 doses of the Pfizer vaccine have been administered in this age group, over 257,000 are dose 1, and then almost 174,000 dose 2s. So in the 1 to 21 day risk interval, we've electronically identified a small number of cases for appendicitis, you can see 9 cases, seizures, which are 2, and then 2 cases of myocarditis and pericarditis. So far, the 2 potential cases of myocarditis and pericarditis have been chart reviewed. And of the 2, chart review verified 1 11-year-old acute pericarditis 19 days after dose 2, and the other case was not verified as a case upon chart review. And there have been no statistical signals that have been identified to date. Next slide, please. So in summary, for the analyses of safety amongst 12 to 17 and 5 to 11-year-olds, among 12 to 17-year-olds, the rate ratio for myocarditis, pericarditis was elevated during days 0 to 7 after dose 2. The excess risk was 0.3 cases per million first doses, but it was 70 cases per million second doses. The VSD has administered over 431,000 Pfizer doses to children aged 5 to 11. And in the VSD, there have been no safety signals among 5 to 11-year-olds that we're continuing to monitor. Next slide, please. And I'd like to, as always, acknowledge just the hard work and really amazing work of our team here at Northern California Kaiser Permanente, as well as the CDC and Marshfield Clinic and all the VSD sites are very active participants in the chart review process. Thank you very much.
Thank you, Dr. Klein. And again, thank you to your team, as well as all the vaccine safety teams for working over the holidays to update and get this data to us. This presentation is now open for questions. Dr. Daly?
Thanks for that presentation, Dr. Klein. Could you go back to the slide showing the date that first and second doses of vaccine were given to 5 to 11-year-olds?
Sure. I think that slide 20. Could you go back there, please?
Okay, thanks. So Dr. Klein, could you speak to the idea so if kids in this age group were going to get myocarditis, we think that might happen in the 7 days after vaccination, particularly after dose 2. But could you speak to kind of how quickly that would be observed within the VSD in terms of sort of they need to come in and be seen, and then what's the sort of data lag, and when is that peak for the second dose happening? So I'm just sort of asking, do we have enough follow-up time for these kids to have potentially seen myocarditis after the second dose in 5 to 11-year-old kids? Thank you.
So as I think I mentioned, our data, generally the data lag is, as you're aware, is quite We actually get data quite quickly. It depends, each VSD site's a little bit different. Some are a little bit have less data lag than other sites, depending on how the relationship with their inpatient hospitals. But in particular for this data actually goes through December 11th. So because of the holidays and what have you. So this data has not been updated since then. So there hasn't been a lot of follow-up time for those dose twos to occur, which is if there is any risk for myocarditis, then it follows a similar pattern to what we've seen in the adolescents and young adults. It would be typically after dose 2. And so there hasn't been a lot of follow-up time to date for the dose 2.
Okay, thank you.
Yeah. Any other questions? I'm waiting to see if people would like to raise their hand. I actually just wanted to make a quick comment because every time I hear the data presented, I glean a little something different from it. And I think what was interesting is noting the long interval of follow-up. So many of these kids after discharge are not being followed up within a week or two. I think you said the median may have been 88 days, or mean was 88 days, I cannot remember. But suggesting that, those kids who are following up at 3 months post a hospitalization are probably doing their routine follow-up, but not necessarily are acutely ill, else I would have anticipated they would have come in sooner. So I think that's also helpful to see. Any other questions for Dr. Klein? Dr. Peeling?
All right, yes, thank you for this presentation. And it is impressive how much information you've been able to glean. I did want to ask you a similar question. And in the cases that you have seen, have you seen any deaths or any severe outcomes? Thank you.
Yes, thank you for that question. So we have not had any deaths. All the patients that we've been following in VSD all were discharged home after their hospitalization. With regard to severity, I think the best measure we have is those who were in the intensive care unit. And so, as I mentioned, that there were 11 of them who were in the intensive care unit, although 2 were for preventative measures and 1 for actually unrelated issues for the myocarditis. So I guess 8 out of those 43 that we have, I believe it was 43 that were perhaps in the ICU, if you want to consider that the severity. But we don't have further information regarding what happened in the ICU. We're investigating that now.
Thank you. Dr. Daly?
Yeah, Dr. Klein, could you just explain for sort of the broader audience what you mean by preventive measures if somebody gets admitted to the ICU?
Well, as according to the chart notes, it was meant to be just in case the child decompensated or had clinical deterioration, to be available and ready in a setting that could manage it, which is why the child was in the ICU, not because the child had the clinical indicators that required them to be in the ICU in the first place. It's more to be just in case something happened and everyone would be ready to take care of the child should the child had some clinical deterioration.
Great, thanks so much for that clarification.
Thank you. Are there any other questions? Well, I want to thank our presenters for an excellent series of presentations and updates on vaccine safety, both for the primary series as well as on booster doses. We will now take a break, and we are running behind schedule, so I'm going to suggest just a little over a 10-minute break. We'll plan to reconvene at 50 minutes after the hour, 50 minutes after the hour, after which we will return for public comments. So thank you, everyone, and look forward to reconvening soon. Good afternoon. It is now 50 minutes after the hour, and we'll reconvene the ACIP meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and I realized there wasn't very much time, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and again, in order to make it through all of the listed speakers, it's extremely important each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. As a gentle reminder, our committee appreciates diverse viewpoints that are respectful in nature and issue-focused, rather than comments directed at individuals. Thank you again to our speakers, and we look forward to your comments. Our first public comment speaker for today is Dorit Rice.
Can you hear me?
We can, thank you.
Thank you for the opportunity to comment. My name is Dorit Rice, and I'm a professor of law at the University of California, Hastings College of the Law. I have 4 points to make. I hope I can get through them. First, I want to reiterate how useful and important it is for you to have these open, transparent discussions. As Dr. Cohen pointed out, you've met for over 24 days. And to thank the committee members, the guests, and professional staff for preparing these labor-intensive presentations on vaccine safety. Thanks to you, we, the online advocates, have a good answer when anti-vaccine activists try to claim the safety data is not looked at, because you provide the data and committee members ask penetrating questions that get more information about it. I know it's a lot of work. I want you to know that it really matters. Second, I'm not a scientist, but I am a parent. My kids, like millions of kids in the United States, are going back to schools. Our schools are taking precautions, but with Omicron, that may not be enough, and not all schools are. I know you will focus on the science, but I want to ask you to consider, among the benefits, the effect of children's lives and their parents of how vulnerable they are to infections in school. Even if vaccinated children don't get severely ill from Omicron, their life has been already disrupted. At least most of them don't get ill, I hope. And if a booster can reduce the risk of disruption in a meaningful way, that matters. Third, Dr. Cohen pointed out that you're moving to have more recommendations done by CDC without ACIP input, which, given the extensive work ACIP done, makes sense. Yesterday, the CDC published a recommendation about 2 of the 3 things the FDA authorized, and some people asked whether the CDC has already made up its mind before hearing from the committee. It's great that the CDC is mindful of the limited number of the experts in the committee and not using that time for smaller items, but I hope you consider the messaging there and make it clear when and why things go to the committee and when and why they do not. And going forward, it might be a good idea to add a line on why CDC decided that this does not need ACIP input, just to avoid appearances of not listening. Transparency about the process is really important right now to maintain trust. Finally, on process, there's a real problem, and this is directed more at the CDC's committee staff than the committee members. The agenda for this meeting only went up around 8 a.m. my time today, 11 a.m. Eastern time. The public commenting announcement came later, and this is the second time it's been day off. I realize it's an emergency meeting, but the Federal Advisory Committee Act requires notice in advance for transparency, and that really matters. Anything you can do to have the agenda up 1 or 2 days in advance and have the commenting up will make a real difference. I know you're under a lot of pressure, but day off really is an issue. Thank you very much.
Thank you for your comment. Next, we have Mr. Kermit Kubitz.
Oh, my name is Kermit Kubitz, and I have no conflicts. I have, as an early vaccinated person at the San Francisco Veterans Administration, been a substitute in-class IT person while teachers taught remotely, and I turned on projectors and counted students at a local high school. And this experience informs my comment. I support booster doses for adolescents for 3 reasons. The first is the startling increase in COVID cases among children. The second reason is the benefits of vaccination in reducing infection and spread among school-aged children to others, including teachers and the unvaccinated. The third reason is the protection boosters give against existing and possible new variants, including Delta, Omicron, and future variants. First, there is a rapid increase in COVID-19. New COVID-19 cases in children in the U.S. increased nearly 64% over the prior week, according to data published by the American Academy of Pediatrics. For the week ending December 30th, there were more than 325,000 new cases among children, the highest count ever reported in children over the case of the pandemic. While it appears that severe illness due to COVID-19 is uncommon among children, there are still threats to immunocompromised patients and those with whom they interact. A second reason for vaccination and boosters for children and adolescents is to keep children in school, participate in sports and other group activities. Schools in Marin County have had to close gyms to spectators, and schools in Chicago have had to go back to remote learning and undesirable retrogression. The final reason for boosters is to protect against both existing variants such as Delta and Omicron and new variants such as the multi-mutation variant recently identified in France, IAQ, that causes COVID-19, also known as B1640.2. While its severity and infectiousness are not known, boosters will clearly produce more protection as we go forward. I thank you for the opportunity to comment as I have on previous December 1st and December 12th and June 24th ACIP meetings, and I thank you for your work and best wishes for the new year as we get this pandemic under control through vaccination. Thank you very much.
Thank you for your comment. Next, we will move on to Joan Edelstein. There we go. Go ahead. Please go ahead. We still can't hear
I'm
you.
having trouble with the sound. I hope it's...
Okay, we can hear you now. Thank you. Please go ahead.
I'm Joan Ellenstein, a registered nurse with a doctorate in public health and faculty in the School Nurse Credential Program at the California State University in Sacramento. Thank you for the opportunity to comment. I have 3 points to make. One, we all so value the work of this committee to truly rely on the science and evidence in making recommendations for vaccines that are clearly safe and effective and completely support the committee recommendations. Unfortunately, we have not had clear, consistent messaging from the CDC, leaving risk decisions to individuals because of the confusion caused. That includes not following expected protocols and announcing changes before the appropriate committees meet and their recommendations. Second, I again raise the issue of the need to actively involve and model a relationship with school nurses who care for our country's pediatric public health population to have a successful vaccine campaign. The CDC has noted school nurses are trusted vaccine ambassadors. In studies of HPV vaccine, for example, a controversial vaccine, intervention schools have higher rates of vaccination than non-intervention schools. We know that engaging parents in schools increases vaccine uptake. As in all areas of healthcare, we are losing school nursing staff at a critical juncture. The CDC should include in all school-related recommendations that school nurses be actively included in assessment planning, policy, program development, implementation, and evaluation of both vaccine programs and mitigation efforts. Funding should be targeted to school nurse positions. Rather than eliminating or ignoring school nurse positions in districts, the CDC should take the lead in recognizing the importance of including school nurses in all recommendations and enjoining state, county, and city health departments to partner with school nurses at the district and school levels to carry out this critical task of getting our pediatric public health population vaccinated. I ask that the CDC work directly with the National Association of School Nurses to help improve vaccine outcomes, especially in vulnerable communities with lower rates of vaccination. On CDC process number 3, I so appreciate the work of this committee made even more difficult by the demands of the pandemic. Having the agenda posted the day of the meeting rather than in advance for both transparency and meaningful public participation would be helpful to change. In submitting a request for public comments, it feels like the CDC Oscars. Those of us who put in the request must make their acceptance speech in advance only to find out just before the meeting whether they've won. If public comments are at the beginning of the meeting, notice may arrive in the middle of the night for those of us on the West Coast. Thank you very much for this opportunity to speak, and I wish you a healthy, happy, pandemic-free year.
Thank you for your comment. Next is Dr. Julie Boom.
Thank you so much. On behalf of Texas Children's Hospital, I would like to thank the CDC staff and ACIP members who have so diligently analyzed COVID-19 disease burden, vaccine safety, and efficacy data, and then so adeptly provided risk-benefit assessments based on this information. Using your in-depth analyses, my colleagues and I have been able to assure families about the safety and efficacy of COVID-19 vaccines for all persons 5 years and older. As a general pediatrician with 26 years of experience and director of the Immunization Project at Texas Children's Hospital, I know that vaccines are the best way to protect all persons from COVID-19 and are our best hope for ending the pandemic. As you continue your discussions today, I urge you not to minimize the disease burden and risk of COVID-19 in children and adolescents. With the arrival of the Omicron variant, children's hospitals across the nation are reporting dramatic increases in COVID-19 hospitalizations. To date, almost 7 million children have been diagnosed with COVID-19, resulting in over 80,000 hospitalizations and more than 1,000 deaths. Early data suggests that the Omicron variant is more contagious and spreading quickly through our pediatric and adolescent populations. Additionally, Omicron has resulted in breakthrough cases following full vaccination at record levels. Fortunately, early data suggests that booster doses may mitigate this phenomenon. As COVID-19 vaccine was initially approved for children 12 years and older on May 12, 2021, many adolescents could already be experiencing waning immunity and could benefit from a booster dose. As we near the 2-year mark of the COVID-19 pandemic, we must do everything in our power to minimize any further detrimental effects to the mental health, physical well-being, and education of U.S. children. Because of Omicron surges, many educators are again facing the difficult decisions regarding the safety of in-person learning for both teachers and students. For these reasons, a booster recommendation for children 12 years and older cannot come soon enough. Please give these factors your strongest consideration as you weigh the benefits and risks of COVID-19 booster doses for children 12 years and older. Thank you so much.
Thank you for your comment. Next, we have Dr. Richard Paul Junghans. Do we have Dr. Junghans on the phone?
Hey, Dr. Lee, he was on the line. Now I don't see him.
Can you hear me?
Now we can hear you. Thank you very much.
I'm sorry. I had you on mute. Had me on mute. I'm Richard Junghans. I'm a medical oncologist and hematologist and immunologist with 30 years experience in the field of immunology. Title of this is Saving Jobs, Lives, and Vaccines, Exempt Prior Infectees from Mandatory Vaccination. I am pro-vaccine. Whereas vaccinating everyone makes sense, there is a nuance to the situation with vaccine-averse people that can be exploited to everyone's benefit. Let's say 50% are vaccinated and we want to get to 100%. We provide incentives, we threaten their jobs, and in general try to shame people as healthcare troglodytes to get their vaccinations done. I want to appeal to the science, not politics, not morality, not expediency. That is, let us find the population that is truly at risk and reduce the focus to this subset. The population at risk are those who have neither been vaccinated nor infected. So far, public health agencies have chosen to ignore prior infectees and treated them the same as the susceptible population. This is a gross error and a missed opportunity. In general, the consensus view is that natural immunity that arises from exposure to all viral proteins is superior to vaccine immunity with exposure to one viral protein. Accordingly, I propose that all prior infectees be designated the same as vaccinated, as is currently being done in Israel with issued green cards. Unfortunately, the CDC has not followed the data to make this recommendation, which only favors profits of the vaccine manufacturers, subjects rare patients to medical risks, and does not increase the safety to those already naturally immunized by infection. And it also decreases available doses to countries who are desperately underserved. In April 2021, CDC estimated 40% of the adult population was previously infected, with a much higher likely prevalence among frontline workers whom we disproportionately target with mandatory vaccination. The impact: if we exempt prior infectees, this legitimately reduces the at-risk group from 50% down to 25 or 20% or lower, much more manageable numbers. Any prior positive PCR, antigen, or antibody test exempts them. Not everyone had proof of prior infection, but offering antibody tests to non-vaccinated employees will inform, and if positive, they are exempted. This has the further benefit of engaging the employee in his or her own health choices and more likely to be agreeable to vaccination when offered after a negative test. If we follow the science and avoid aggressive, even classist mandates that selectively impact the poor economic classes with these threats, then this proposal to treat prior infectees as vaccinated is an easy choice, respectful, without caprice or arbitrariness, and it follows the science, not politics. In this case, I predict this proposal will increase vaccine participation while also decreasing social strains. I will post online further supportive documentation. Thank you.
Thank you for your comment. And I want to thank all of our public comment speakers. We really truly value your public input in these meetings. And next, we will move on to the session that will begin with, I believe, Dr. Evelyn Twentyman will provide the committee an update on clinical considerations, including and incorporating some of the recent updates from earlier this week. Dr. Twentyman.
Thank you so much. Could we bring up the slides? Give us one moment. We're having some technical difficulties. We'll be back ASAP. Thanks, everyone. We're going to take a 5-minute break. We'll be right back. Good afternoon. I'm pleased to say that we're back online. Can everyone hear me?
Yes, we can hear you.
Thank you so much, and apologies for our technical difficulties. My name is Evelyn Twentyman, and I currently serve as Chief Medical Officer for CDC's COVID-19 Response Vaccine Task Force. I will be providing a high-level overview of some of our recent updates to our interim clinical considerations for use of COVID-19 vaccines, as well as a preview of updates to these interim clinical considerations planned to follow today's ACIP meeting. Next slide, please. Over the next few minutes, we'll draw your attention to some of the most recent updates to these interim clinical considerations and our anticipated next steps. We'll briefly review highlights from each of the last 3 updates made throughout the month of December, and then turn our attention to updates we anticipate coming later this week, including any outcomes of our meeting today. As you can see here, we'll touch on our updated guidance for booster doses in adolescents ages 16 to 17 years, updated guidance on use of the Janssen vaccine, including ACIP and CDC's preferential recommendation for mRNA vaccines for both primary series and booster doses, and our description of the newest formulation of Pfizer-BioNTech's COVID-19 vaccine, also known as the Gray Top. And then we'll turn to updates we expect later this week. You'll see here that, of course, we anticipate including guidance to reflect outcomes of today's meeting, including any recommendations ACIP decides to offer. And we'll also briefly describe 2 additional updates to make based upon FDA's regulatory actions Monday, with recommendations by CDC through decision memos announced yesterday, including recommending a 3rd Pfizer-BioNTech primary series dose for children ages 5 to 11 years with moderate to severe immunocompromise, and a decrease in booster interval after Pfizer-BioNTech primary series from 6 months to 5 months among those who are booster eligible. Before beginning, I want to caveat that this is meant to provide you with a nice high-level picture of what most significant changes have occurred most recently and those that will come next. We did make a number of other small updates over the course of December to ensure alignment with updated links or language or guidance for specific providers or professionals, and have made many other evidence-based updates to our guidance since COVID-19 vaccination began over 1 year ago. We won't be able to discuss every one of these here, but before moving on, I wanted to note that you can find a list of all historical updates to our interim clinical considerations by either going to the interim clinical considerations page and scrolling to the bottom, or you can simply click this link here at the bottom of this slide and go immediately to this entire list. Next slide, please. First, we'll describe our latest updates. Next slide, please. On December 10th, we updated our interim clinical considerations to include guidance that adolescents ages 16 to 17 years may receive a booster dose of Pfizer-BioNTech COVID-19 vaccine at least 6 months after completion of their primary series. As you might recall, as we discussed briefly at our most recent ACIP meeting, this decision was based on data previously reviewed by ACIP, though not specifically discussed and voted upon then, as it was not relevant in the context of emergency use authorization, or EUA, for Pfizer-BioNTech at that time. Given, however, the reassuring safety data ACIP had recently reviewed, the relative vaccine efficacy for booster vaccination of more than 95% among adolescents who had received a recent booster compared with those who had not, and the need for it, as evidenced by the emergence of the Omicron variant and the number of adolescents who would be immediately eligible, it was recommended, following FDA's amendment of the Pfizer-BioNTech EUA, that people ages 16 to 17 years may receive a booster dose based on their individual benefits and risks. Next slide, please. On December 16th, ACIP reviewed updated benefit risk assessments pertaining to the Janssen COVID-19 vaccine in the context of identification of additional cases of thrombosis with thrombocytopenia syndrome, including deaths, and in the context of increased supply of alternative mRNA vaccines in the US. ACIP voted that mRNA COVID-19 vaccines are preferred over the Janssen vaccine for the prevention of COVID-19 among those who are eligible for either mRNA or Janssen vaccine. Next slide, please. Then, moving forward to December 23rd, just in time for the holidays, ordering opened for the newest authorized formulation of the Pfizer-BioNTech COVID-19 vaccine, nicknamed Gray Top. We updated our interim clinical considerations this same day. To briefly highlight differences between this Gray Top formulation, for which ages 12 years and older are eligible, from the previously released Purple Top formulation for the same age group, the Gray Top formulation does not need dilution, can be refrigerated longer, can stay at room temperature longer, and can remain in use after first puncture twice as long as its Purple Top predecessor. Next slide, please. And now turning to a new month and a new year. Next slide, please. On Monday, FDA extended authorization of a third primary dose for certain immunocompromised children ages 5 to 11 years, and CDC followed this with the same recommendation in a decision memo announced yesterday. There was some sense of urgency here in our eagerness to protect children with moderate to severe immunocompromise. We have seen that vaccine efficacy is lower in patients with immunocompromise. CDC does already recommend a third primary series dose in those aged 12 and older with moderate to severe immunocompromise. We know that approximately 1.4 million children in the US ages 5 through 17 have an immunocompromising condition consistent with our definition of moderate to severe immunocompromise, which we'll review momentarily. Only those immunocompromised children ages 12 to 17 in this group, however, were previously covered by this recommendation to receive a third primary series dose. In addition to this sense of urgency, we have a quite encouraging sense of safety at the same time, thanks to the reassuring findings of vaccine safety surveillance for children ages 5 to 11 years. You've seen some of these data presented already today and published in this MMWR report on December 31st. For now, and in the interest of time, I'll underscore again that during administration of more than 8 million doses of Pfizer-BioNTech to this group, serious side effects were rarely reported. Next slide, please. I promised we'd review our definition of moderate to severe immunocompromise, and here it is. You'll see our same 6 clinical categories here, as our working definition has not changed, and we can now say that children ages 5 to 11 with one of these conditions can now benefit from a third dose in their primary vaccine series. Next slide, please. We have also gone forward with a decision memo recommending a decreased booster interval of 5 months for those booster eligible following completion of a Pfizer-BioNTech primary series. Our sense of urgency here came from the rapid expansion of the Omicron variant, with which I'm sure you're unfortunately very familiar, and with observations that people who have completed both primary series and booster may be better protected against symptomatic infection with the Omicron variant than those without booster. In addition to that, we can learn from the experience of our Israeli colleagues who have used a 5-month booster interval in their administration of Pfizer-BioNTech vaccine and observed effectiveness against severe illness and death when compared to those without booster. We could detect need for this in the US, given that as of yesterday, just 38% of fully vaccinated adults have received a booster. Many adolescents are potentially eligible as well. As of Monday, over half of US adolescents in the currently booster-eligible age group are vaccinated, but only 6% of these have received a booster. Lastly, turning back to the experience of Israel again for a moment of some safety-related observations of the 5-month booster interval, those rare occurrences of myocarditis in people ages 16 years or older after their second dose were even more rare following a booster dose. Next slide, please. I'll wrap up with an explanation in visual form here, demonstrating vaccine booster dose by primary series. At least 5 months after completing a Pfizer-BioNTech primary series, at least 6 months after completing a Moderna primary series, and at least 2 months after completing a Janssen primary series, people who are booster eligible can receive any of the vaccine products for which they are eligible. I'll also offer a comment on eligibility here, as the age group eligible for Pfizer-BioNTech booster may change based upon outcomes of today's meeting. You will see updates to our interim clinical considerations include any outcomes of today's meeting in addition to these updates I've just described. Next slide, please. With that, I'd like to pause to thank the many hardworking people who have contributed to this presentation, to our rigorous understanding of vaccine safety, and to our frequently updated evidence-based interim clinical considerations. And next slide, please. I'd like to thank you for your time, and I'm happy to take any questions. Thank you.
Thank you, Dr. Honeyman. This presentation is now open for questions. Ms. Bata.
Thank you so much, Dr. Honeyman. I don't really have a question as much as I have a comment, and it's just, again, from that perspective of practicality and feasibility. We've got 3 COVID vaccines with 3 different intervals, and this complexity is really confounding to play out practically. And I know that as a ACIP decision maker that we can't do much about that, but I'm hoping that you will have some good clinical consideration guidance if some of these, if something like Moderna is given at 5 months instead of 6 months, because I know that that's going to be happening. Thank you.
Thank you, Dr. Bata. We do endeavor to make our clinical guidance as easy to follow and as intuitive as possible for the American public and the healthcare providers that serve them. And we will continue to do that in any context we're working in, such as these 3 different booster intervals that we have as of today, and we will continue to frequently update our recommendations as soon as we can, given any updates to policy or authorization in the future. Thank you.
Thank you. Dr. Long.
Yes, it's a question a little bit for the CDC leaders there and for you, Dr. Lee, about what comes to this committee and what does not. For instance, if we don't see data and we just hear about these things, these interim recommendations that are changing, we don't have an opportunity to question the data, to expose what is available and what the big gaps are. For example, we saw some data about immunocompromised in response to vaccine very early on, but everything else has sort of been tagged on. And obviously, I want to protect children 5 to 11 who didn't respond to the vaccine, first 2 doses, with another dose. But I think this is exactly the age group and the condition in which the risk of myopericarditis is significant if they responded to dose 1 and 2 to get another dose in the presence of high antibody to spike protein to get another message for spike protein. And these are children whose hearts may be challenged by chemotherapy and steroids and drugs and other things. So my question is, has the work group seen the data along the way and agrees with the change in, the changes? For instance, let's just focus on the inclusion of a 3rd dose for 5 to 11. Because I would think, since many transplant centers and many others are doing semi-quantitative or quantitative antibody tests, and because the CDC has said we don't count on those because we don't have a marker of protection, I think we're losing the ability to know that if someone has a high antibody to spike protein, we know they've responded to the vaccine. And I think those are the ones who are particularly at risk for myopericarditis. and would say this is not the time to give them a dose because the numbers that I have seen, they're either nothing, and of course they need it, or they're extremely high after the second dose, and I wouldn't want to give that child a third dose. So a little bit question about process and a little bit about has CDC reconsidered as antibody tests are, probably reproducible now, considering the use of those in immunocompromised to make the decision for the third dose at 3 months. Thank you. Sorry.
Thank you, Dr. Long. I want to see if our colleagues in the room at CDC would like to comment, and I'm happy to provide my opinion.
Dr. Long, thank you. This is Melinda Wharton. Regarding what questions will be coming to the committee and which ones aren't, for the incremental extensions of recommendations, we do not, these have not all come to the committee, and we probably will be having fewer of them come forward in the future because of the limited amount of additional information available to address those. There's a number of substantial issues that we would really like to be able to engage the committee to discuss, and I think we're going to try to increasingly focus in that direction going forward. Dr. Lee, do you have additional comments?
Sure, I'm just going to share my opinion, and I appreciate the question, Dr. Long, because it's something that I think we as a committee have been struggling with. I'm going to give a long answer. I hope that's okay. In routine scenarios, ACIP, of course, deliberates on new vaccines, new indications or contraindications, new schedules, et cetera. And our goal is to ensure that we are providing a timely response following FDA authorization or approval of a new vaccine product or a new indication. Those meetings are typically 3 times a year and, as you know, well scheduled in advance. In a pandemic scenario, we are under a public health emergency. I mean, timeliness is essential for all of us, and we know this based on our frontline work as clinicians or as public health practitioners. And we recognize that decision-making is typically in the context of uncertainty. So, in my view, ACIP should continue to serve the purposes it was set out to do, which is number one, to provide advice and guidance to the director of the CDC regarding use of vaccines and related agents to effectively control vaccine-preventable diseases, in this instance, COVID. And number two, to ensure that the public has knowledge of and an opportunity to provide public comment on meeting topics in order to ensure transparency in our decision-making and enhance public trust. But I also have to just comment that the urgent demands of the pandemic response and the way that our committee is structured has created challenges. And so we have to acknowledge those challenges and make sure that we are continuing to fulfill our function and role, but allow our public health agencies the flexibility to respond in a timely manner. And, I anticipate that we are going to be hearing from our FDA colleagues on a fairly routine basis, as there's a series of decisions that we anticipate will be coming quickly, over the next few weeks, months, and, beyond a few months. So in order for us to be responsive as an agency, I hope that what we can do is focus on issues that impact overall population benefit risk balance and where public discussion is critical for transparency and trust. So, I anticipate we will continue to evolve, but I do want to recognize that the demands on ACIP have been far above and beyond a typical federal committee structure, and that I think we're going to have to learn together about making sure that we are serving our purpose and our function while also being responsive to the pandemic. So we recognize that, again, every emergency meeting, we ask our ACIP members and our liaisons and our CDC staff to attend adds additional burden. And we are trying to find a way, as Dr. Cohen mentioned early on, to continue to make this feasible, sustainable, and impactful in terms of the discussions that happen. But this is, just my opinion. And I do think we need to enhance the predictability of these meetings, as was mentioned multiple times over the course of today. And we need to be able to support a sustained response, because I don't think things are going to change. I was hoping we would be done after a year. I was hoping we'd be done after 2 years, and it's becoming clear to me we are heading into year 3, and we are not done by any means. So, welcome additional comments or feedback on that approach, but again, these are just my opinions. I'm going to move on to Dr. Sanchez.
Thank you, Grace. I don't think we will ever be done, but that's personal. We'll just have to live with this and control it by vaccination and other means. But my question, certainly the myocarditis has been the concern throughout. And as I was looking at this immunocompromised children and the recommendation for an additional primary series, has there been much myocarditis, and thinking about the pathogenesis and of course booster dosing then for the 12 to 15-year-old as well, has there been much myocarditis that has been reported among the 1.4 million children who had an immunocompromised suppressive condition? I think it seems to be that those children really have not had much, and maybe it's because of the lack of antibody production, or just trying to sort through some of the pathogenesis and some of what Dr. Long was saying. It seems to me that the myocarditis has not really been an issue with those individuals, and whether it may be after a third dose.
Dr. Sanchez, this is...
Great, thank you. Go ahead.
This is Dr. Oliver. I just want to say, so agree with you that, if we think through, so many of the, and I'll see if Dr. Shimabukuro wants to specifically comment there. I think we don't have kind of specific surveillance for myocarditis, solely in immunocompromised populations, but I think it does, from a pathophysiologic, make sense that the children who are immunosuppressed and not having kind of these robust immune responses may not be the highest risk population for myocarditis after these doses. So I think the consensus kind of on the work group was exactly what you mentioned. Dr. Shimabukuro, any kind of comments from y'all's surveillance?
I'll just confirm that we don't specifically conduct safety surveillance in immunocompromised populations. I will say that we review all case reports of myocarditis that come into VAERS in an attempt to follow up and get medical records or contact the physician as part of our adjudication to see if they meet case definition. And I'm not aware of any unusual or unexpected findings in these case reports with respect to immunocompromising conditions. So I don't think that we have any evidence to suggest a safety issue, above and beyond what we're observing in our routine surveillance for the specific immunocompromised patient population.
Thank you. We'll move on to Dr. Peeling.
Yeah, thank you, Dr. Twentyman and the entire committee for this robust discussion. I wanted to make one comment, and that is that I've received many questions about providing additional coverage for immunocompromised children that were younger than 12. So this will be welcome news for many. And then I wanted to ask a point of clarification. So the children who are immunocompromised down to 5 can now receive a third primary dose. Would they also then be eligible 5 months later to get a booster dose? Thank you.
Thanks so much for your question. Children ages 5 to 11 are now eligible for a third dose in the primary series who have moderate to severe immunocompromise. This age group is not yet booster eligible. So thank you for asking this question, because it allows us to draw a distinction between primary series and booster. And what we're talking about in these 5 to 11-year-old kiddos with immunocompromise is a third dose in the primary series. Does that help? Thank you.
Yes, thank you.
Thank you. Dr. Daly. For some reason, I can't hear you, Dr. Daly.
Okay, I'm having mic problems. Can you hear me now?
We can, thank you.
Okay, my apologies. I'm on a loaner computer in clinic, and so it's been difficult to connect. So I have a couple comments. One is Dr. Long asked whether the work group had reviewed new data about antibody titers in immunocompromised 5 to 11-year-olds, and no, in the last few weeks we have not. I mean, I think I want to emphasize a couple points and then maybe ask Dr. Cotton to weigh in. But you know, Dr. Long, part of the process that got us to this point was the FDA's review of their interpretation of risks and benefits of vaccination of immunocompromised, and then their assessment that the benefits strongly outweigh the risks. But then to the second point about kind of what should come before the committee, you know, I do know that there was a lot of discussion from leadership at the CDC about what should the committee discuss today, and the decision was made to focus on the booster doses in the 12 to 15-year-olds, but that doesn't mean we can't sort of think about, talk about, and comment on the other issues, you know, in front of us. And then I think I would ask Dr. Cotton, if she's on, if she could comment about her perceptions about additional doses in 5 to 11-year-olds who are immunocompromised. Over.
Thanks. It's Camille Cotton. I'd be happy to comment, although I'm not a pediatric provider, but what we are seeing in immunocompromised patients is a marked reduction in vaccine efficacy and protection from disease. And so I do think that with Omicron, things are really different than before as far as vaccine efficacy, and I really think that now is the time to think about additional doses of vaccine actually for all immunocompromised patients, perhaps starting as early as maybe 4 months after their last dose, after they finish their primary series. And I really think this is an important opportunity to think about that. One thing that hasn't really come out of the discussions today is the overall risk of developing myocarditis and other life-threatening conditions, not just from vaccine, but from disease itself. I am seeing devastating amounts of disease in immunocompromised patients. I'm seeing, I know that in general, Omicron is touted as being less severe. However, for poorly vaccine-protected immunocompromised patients, I'm seeing life-threatening disease. I have numerous patients who are on life support in the intensive care unit. We've had other patients die. This is a horrible state of affairs for immunocompromised patients. So although we've been deliberating a lot about vaccine side effects, I would really like to also focus on disease itself, which is astronomical proportions. And although I know that the immunocompromised patients I care for have been very, very diligent in avoiding getting infected, the highly infectious nature of Omicron is such that patients who've been incredibly careful for the better part of the past 2 years are now getting infected with awful outcomes. So I would both advocate for better examination of how devastating disease can be, especially at the rates we're seeing, but also I would really like to advocate for additional doses of vaccine for all immunocompromised patients. Thank you. Thank you, Dr. Daly and Dr. Cotton. Dr. Sanchez?
Thank you. I just had a comment. So, or a question or clarification, I guess. So the immunocompromised child, 5 to 11, who has received a 10 microgram dose, I assume that as with similar recommendations before, once they reach, if they've already now 12 years and older, they will be getting a booster with a higher dose?
I think perhaps that is one of the discussion points for today. I don't know if Dr. Oliver wants to address that now or if we want to move on to Dr. Oliver's presentation next. But I think just to clarify, go ahead.
Can we just clarify that children who change ages, at least once a year, are dosed according to the age they currently are? So I think I heard the question to be if they were voted into eligibility at the age of 12 for booster today at this ACIP meeting, if they previously had a dose of 10 micrograms, would that change their dose of booster between the ages of 12 and 15? And I'll just go back to our guiding principle that children, as all individuals, are dosed based on their current age at the time they go for vaccination, according to our clinical guidance. Does that help? Thank you.
Yeah, no, that's perfect. I just wanted clarification. Thank you.
Any additional questions? Any questions from our liaison members? Recognizing implementation is challenging. Okay, I see no further hands raised, so we will move on to Dr. Sarah Oliver, who will walk us through the updates to the evidence to recommendation framework for boosters for 12 to 15-year-old patients.
Dr. Lee, give us just a second. We're getting the slides back up.
Thank you.
All right. Thanks so much and good afternoon. Next slide. So just as a reminder, this is the ETR framework that we've used for our previous booster dose recommendations. Next slide. Then this slide shows a timeline of the recommendations for COVID-19 booster doses over the last several months. We first reviewed data and voted on booster doses for the Pfizer vaccine in September. Then in October, this expanded to the Moderna and Janssen vaccines, including recommendations for heterologous boosting. In November, the booster recommendations were broadened to include all persons 18 years of age and over. In December, this was extended down to 16 years of age. Then in January to date, we've shortened the interval between the primary series and booster dose to 5 months for the Pfizer vaccine. And next slide. Then today we're discussing booster doses for those 12 to 15 years of age. Next slide. So then as a reminder, this is the visual for the current recommendation for booster doses. Booster doses are recommended as a should receive the booster for all 18 years of age and over. The interval between the primary series and the booster depends on what primary series was received. Then those 16 to 17 may receive a booster at 5 months after the receipt of their Pfizer primary series. Next slide. So this is the policy question we'll be discussing today. Should individuals 12 to 15 years of age receive a Pfizer-BioNTech COVID-19 vaccine booster dose at least 5 months after completion of the primary series, based on the balance of benefits and risks? Next slide. So moving to the public health problem, next slide. As of January 3rd, there have been over 56 million cases of COVID reported in the US. Cases have rapidly increased starting in early December due to the increasing prevalence of the Omicron variant. As of January 3rd, the 7-day average had reached an all-time high of nearly 500,000 cases. Next slide. Then this figure shows the nowcast projections, showing the increase in the prevalence of the Omicron variant that's shown in purple. As of the most recent week available, ending on January 1st, Omicron made up over 95% of cases. It's important to note that the most recent estimates are drawn from a modeled forecast, the nowcast, that attempts to account for delays associated with testing and genotyping, as well as various biases in surveillance. Next slide. This figure shows COVID-19 incidence rates over time by age group, with the 12 to 15-year-olds represented in yellow. Since this summer, adolescents have had a somewhat higher incidence rate than adults, and are currently experiencing the incidence increase seen across age groups due to the Omicron variant. Next slide. Then this figure shows COVID-associated hospitalization rates by age group, with 12 to 15-year-olds once again represented in yellow. Throughout the pandemic, the pediatric and adolescent age groups have had lower hospitalization rates than adults. To highlight the recent trends in the 12 to 15-year-olds, we'll zoom in the data on the red box, which looks at the pediatric-only age groups, focusing on trends in the most recent months. Next slide. So then this figure shows COVID-associated hospitalization rates among the pediatric age groups from July through December, with 12 to 15-year-olds once again depicted in yellow. Because there are fewer events in these age groups, you can see that there's some variability and the rates bounce around a little from week to week, but we still can see the overall trends. We see a slight increase in hospitalization rates from the summer, but overall rates have remained relatively steady. It's important to note that these dates go through December 10th, and so may not show the significance of the Omicron variant yet. Next slide. Then this figure shows COVID-19 incidence rates among 12 to 17-year-olds by vaccination status. As you can see, the majority of COVID cases continue to occur among the unvaccinated, with unvaccinated 12 to 17-year-olds having about 7 times higher risk of testing positive for SARS-CoV-2 compared to vaccinated 12 to 17-year-olds. Next slide. This figure is similar to the one on the previous slide, but now we're looking at COVID hospitalization rates among 12 to 17-year-olds by vaccination status. Unvaccinated 12 to 17-year-olds have around 11 times higher risk of hospitalization than vaccinated 12 to 17-year-olds. Next slide. We have a few studies that have given us early estimates of vaccine effectiveness in this adolescent age group. The first one we'll discuss is a prospective cohort study, which followed 12 to 17-year-olds in Arizona from July through December to estimate vaccine effectiveness against SARS-CoV-2 infection. Next slide. When comparing 12 to 17-year-olds vaccinated with the Pfizer vaccine with unvaccinated 12 to 17-year-olds, this study estimated an adjusted vaccine efficacy against infection of 92%. Next slide. The next study we'll discuss comes from the Increasing Community Access to Testing, or ICAT, partnership. This is a test-negative study design which covers a period from July through October and evaluated vaccine effectiveness to prevent symptomatic infection. Next slide. In this figure, we see a comparison of the Pfizer-BioNTech VE against symptomatic infection between adolescents 12 to 15 and 16 to 19 years, and then adults 20 years of age and over, by days since second dose, with the 12 to 15-year-old shown in red. VE is the highest among ages 12 to 15, then followed by 16 to 19-year-olds, then adults 20 years and over. And you can see the VE wanes among all age group with increasing time since vaccination. It's important to note this analysis reflects a period with the predominance of the Delta variant. Next slide. In this final study, we look at effectiveness of the Pfizer vaccine against COVID hospitalization among persons 12 to 18 years of age. This was a test-negative study designed in children and adolescents hospitalized at 19 pediatric hospitals from 16 states from June through September. Next slide. This study estimated that vaccine effectiveness against COVID hospitalization in persons 12 to 15 was 91%. And again, this study reflects the Delta dominant period. Next slide. So I want to highlight data from an analysis that will be published later this week. The authors allowed us to share the information preprint through a test negative case control design that included MIS-C cases and hospital controls 12 to 18 years of age from July through December. And they showed that the vaccine effectiveness of 2 doses of the Pfizer vaccine in this population against MIS-C was 91%. 95% of hospitalized children with MIS-C were unvaccinated. The vaccine also attenuated MIS-C severity. None of the 5 vaccinated children who subsequently presented with MIS-C after SARS-CoV-2 infection required respiratory or cardiovascular support. Next slide. So in summary for the public health problem, the US is experiencing a substantial increase in cases over the last month. The Omicron variant represents around 95% of recent US cases. COVID cases and hospitalizations are 7 to 11 times higher in unvaccinated adolescents compared to vaccinated adolescents. And vaccine effectiveness in adolescents 12 to 15 years of age remains high, but may have some waning over time. However, it's important to note that the current VE estimates are primarily in the setting of the Delta variant and may not represent the current situation with the Omicron variant. Next slide. So now as we think through the benefits and harms, next slide. As a reminder, when discussing recommendations for the primary series of 12 to 15-year-olds, we reviewed the Pfizer phase 2/3 randomized controlled trial, which included around 2,000 12 to 15-year-olds in the US. We evaluated all eligible randomized participants who received vaccination as randomized within the predefined window and had no other important protocol deviations with a data cutoff of March 13th. Next slide. The clinical trial for the Pfizer vaccine demonstrated efficacy against symptomatic lab confirmed COVID. There were no COVID cases among 1,000 vaccine recipients and 16 COVID cases among 972 placebo recipients for a vaccine efficacy of 100%. The GMR for antibodies in the 12 to 15-year-olds compared to what was seen in the 16 to 25-year-olds was 1.76, which means it met the non-inferiority criteria. There were no hospitalizations due to COVID or cases of MIS-C reported by any of the trial participants. Next slide. Then for potential harms in the clinical trial, the serious adverse events were reported at a higher proportion of recipients of the vaccine versus placebo, with 5 SAEs in the vaccine group and 2 in the placebo group, but none were deemed related to the vaccine. And serious adverse events were more common in vaccine recipients, with a grade 3 or more reaction reported by 10% of the vaccinated versus 1.9% of the placebo recipients. Next slide. Then as we think through what we know about booster doses, and real-world effectiveness data from Israel, which followed 4.7 million booster-eligible individuals 16 years of age and over, booster doses given 5 months after a 2-dose Pfizer vaccine primary series demonstrated efficacy against confirmed infection in all age groups. Among the 16 to 29-year-olds, the rate ratio for infection comparing the non-boosted group to the boosted group was 17.2. Next slide. Then this data is from the Israeli Ministry of Health website. We heard updated information from Dr. Alroy earlier, but if we look at available information across all populations as of December 15th, you can see that myocarditis rates reported after the Pfizer vaccine in Israel suggest that the rates of myocarditis after a 3rd dose are lower than what is seen after the 2nd dose. Next slide. Previously, they had reported no cases of myocarditis out of 6,000 doses administered, and we heard earlier today that with over 40,000 doses administered, they've had 2 cases of myocarditis in this age group. Next slide. So then highlighting what we know about the impact of the Omicron variant. This slide was presented to ACIP at the last meeting, but in smaller studies that have looked at neutralizing antibodies of vaccinees, neutralization was below the limit of detection for those who received a primary series, either 2 doses of mRNA or 1 dose of a Janssen vaccine. and it moved above the limit of detection for those who either had a booster or had had previous infection. Given limits of detection of the assays and a lack of correlative protection, we don't know exactly what these antibody titer levels translate to protection for either infection or severe disease. Next slide. Then this slide was also previously shown to ACIP and is based on data from the UK. VE with the Delta variant is shown in the box and Omicron in the circle. On the left is a Pfizer primary series, and you can see that there's some waning for both variants over time. It appears to be more pronounced with the Omicron variant. Then on the right, you can see VE with a booster of either a Pfizer or Moderna vaccine. Again, while there's difference by the two variants, you can see that a booster of either mRNA vaccine improves VE with both Delta and Omicron. Next slide. So as we think through the potential benefits of a booster dose in those adolescents 12 to 15 years of age, we know that a 2-dose primary series of a Pfizer vaccine provides protection against symptomatic COVID infection, hospitalization. Now we have data around MIS-C. VE after the primary series is high, but likely is impacted by the Omicron variant. In persons 18 years of age and over in the UK, VE was lower for the Omicron compared to the Delta variant. However, exact estimates of VE against Omicron in adolescents 12 to 15 years of age is unknown. And booster dose has been shown to increase both neutralization antibody level in VE in persons 18 years of age and over. Again, in the UK, a booster dose increased the VE, specifically in the setting of Omicron. Next slide. Then when we think through potential harms, overall the myocarditis rates among 12 to 15-year-olds after a primary series are lower than compared to what we see in the 16 to 17-year-olds. In addition, if we look at the Israel data, they had no cases of myocarditis after 6,000 doses, and again, 2 cases after over 40,000 doses. We know from experience in the older age groups, the rates of myocarditis after a booster dose are lower than what is seen after a second dose. Next slide. So in summary, in the setting of Omicron, we likely have lower vaccine effectiveness in all populations compared to what we've seen with Delta. Higher antibody titers improve neutralization of Omicron variant, and booster doses of COVID vaccines can increase those neutralization titers. The impact of a booster dose on neutralizing antibody, or VE, in adolescents 12 to 15-year-olds specifically is unknown, but it's likely to provide additional protection. And myocarditis rates after a booster dose are likely lower than what was seen after a second dose in younger adolescents. Next slide. So moving to values and acceptability. Next slide. Vaccine uptake among teenagers increased rapidly initially, but has stalled somewhat over the last few months, where around half of parents of children 12 to 17 said their teen has been vaccinated for COVID, and recently around 1% said that they plan to do so right away. About 1 in 8 parents said that they want to wait and see how the vaccine is working, and notably around 30%, or 3 in 10, said that they would definitely not get their 12 to 17-year-old vaccinated for COVID. Although while this data indicates a slowing of vaccine uptake among teens, note that the survey was conducted prior to the emergence of the Omicron variant, and as more information emerges on the potential impact of this variant on children, parents' attitudes towards vaccinating their teenagers or their younger children may change. Next slide. So if we look at vaccination coverage and intent among 3 age groups, adult, the adolescents, and the younger children, you can see that from October to November, almost 80% of adults were vaccinated against COVID, and around 13% reported they were reluctant to get vaccinated. By contrast, for the 12 to 17-year-olds, coverage was almost 60%, with around 20% of parents saying that they were reluctant to vaccinate their child. For those 5 through 11, 8% were vaccinated, 33% said that parents were definitely planning to vaccinate their child, and a quarter were reluctant to vaccinate. And again, the survey was conducted in November, shortly after recommendations for the 5 through 11-year-old age group were issued. Next slide. Then this looks at behavioral, social, and access-related factors by vaccination coverage and parental intent for adolescents 12 to 17 years of age. This slide shows that parents of adolescents who are concerned about their kids getting COVID, are confident in vaccine safety, or have a provider recommendation to vaccinate their child, are more likely to be vaccinated or willing to be vaccinated soon. Parents who are reluctant to vaccinate their child are significantly less confident in vaccine safety and report less vaccinated social networks. But important to note that across all groups, they reported that they did not have difficulty or would not have difficulty getting the vaccine for their child. Next slide. If we look at parental confidence in vaccine safety, parents are less likely to express confidence that the COVID vaccines are safe for their adolescents or children than for adults themselves. Next slide. Then this slide shows the top safety concerns among parents of children 12 to 17. Respondents were instructed to choose their main safety concern around COVID vaccines. As illustrated, the most prominent safety concern among parents was the potential unknown long-term side effects. Next slide. So in summary, vaccine uptake among 12 to 17-year-olds for a primary series has slowed somewhat over the last few months. But as more information emerges on the potential impact of the Omicron variant in children, parental attitudes may change. But we know that parents of adolescents and children are concerned about the potential long-term side effects. Next slide. So moving to feasibility and implementation. Next slide. As of January 1st, roughly 8.6 million of the 16.7 million children or adolescents 12 to 15, which is around 50%, have completed the primary series. Around 5 million adolescents were vaccinated more than 5 months ago and therefore would be eligible for a booster dose. Next slide. Again, as we said, around half of this group is fully vaccinated. Based on our booster experience with other groups, we may anticipate around a third of adolescents who may return for a booster dose shortly after the recommendation. We know that supply of the Pfizer vaccine is robust, and the gray cap that was described earlier will be easier to distribute and administer. We know that currently demand for pharmacy appointments is high, and broadening eligibility could strain this further. Next slide. So now moving to equity. Next slide. Looking at vaccination coverage and parental intent for children 12 to 17 by race and ethnicity, you can see that there was variation where Hispanic children were more likely to be vaccinated than either Black or white children. Next slide. Then this slide illustrates vaccination coverage and parental intent by some county level factors looking at social vulnerability index or SVI and county level urbanicity. While there were no significant differences by the county level SVI, those in urban and suburban areas had higher vaccination coverage rates than those residing in rural areas. Next slide. So in summary, there were noted disparities in vaccination coverage and parental intent by both race and ethnicity and geographic location. Next slide. So in summary, next slide. Dr. Daly highlighted we had a combined work group and VAST meeting yesterday. I'm providing a summary on behalf of VAST, but this represents their interpretation. VAST reviewed the most recent data for the 3 U.S. safety monitoring systems, including data on safety after the primary vaccination series in 12 to 15-year-olds, and after booster doses in 16 to 24-year-olds, the youngest age group for which booster doses have been authorized. No new safety signals were concerns were identified, and at the present time, data did not suggest safety concerns regarding a Pfizer vaccine booster dose for 12 to 15 years beyond what has been identified in the older age groups. Next slide. So now for the work group interpretation. The work group felt, again, the top priority remains vaccination of unvaccinated individuals. The benefits of the COVID vaccine primary series outweigh the risk in all age and sex groups, as the primary vaccination series remains the best tool we have against COVID hospitalization and death. Then as we think through all COVID vaccine recommendations, we want to highlight the goal of the COVID vaccine program to prevent severe disease, including hospitalization and death. We have secondary goals as well, maintaining workforce and healthcare capacity, reduce infection rates and risk of transmission. Then as we specifically think through what may be relevant for this adolescent population specifically, a greater confidence in in-person learning, improved mental health with more social interactions, and prevention of post-COVID conditions. Next slide. Overall, the work group supported the use of boosters in adolescents 12 to 15 years of age. The work group emphasized the importance of clear and consistent recommendations for all adolescents, including those 16 to 17, so for the combined age group of 12 to 17 years of age. And as we have seen over the many ACIP meetings over the last year, vaccine recommendations can and will be updated as needed, especially in a rapidly evolving pandemic. Next slide. So this slide highlights the balance we've used for previous booster dose recommendations. ACIP cannot recommend the intervention. ACIP can recommend the intervention based on the balance of benefits and risks, which we've used as the may recommendation. And ACIP recommends the intervention, which is the should recommendation. Next slide. So the work group discussed the recommendation that adolescents 12 to 15 years of age may receive a booster dose based on the individual benefit and risk. This recommendation acknowledged limited data directly on the impact of boosters in the adolescent population. However, in the current Omicron surge we're experiencing, it provides a recommendation for boosters in a population that could have waning immunity, both due to time since primary series and the impact of the Omicron variant. The work group also discussed the possible advantages of a recommendation for adolescents 12 to 15 years of age that they should receive a booster dose. The work group discussed the difficulty in defining that individual benefit risk balance with the may recommendation and how it can be difficult for vaccine providers to communicate. In addition, in the current Omicron surge, prevention of infection may have larger benefits that are difficult to measure. Mentioned earlier, the population level protection, school attendance, mental health impact. Next slide. Then highlighting that this is the slide, highlights language that was previously in clinical consideration around what individuals and providers could consider as they think through that benefit risk balance with a may recommendation. Next slide. So again, highlighting the policy question for ACIP to discuss today: should individuals 12 to 15 years of age receive a Pfizer vaccine booster dose under the current emergency use authorization based on the balance of benefits and risks? Next slide. Next slide, I think there are two in there accidentally. Before we move to ACIP, I again want to extend my thanks. This did require substantial work over holidays. So the people on this slide, as well as the additional teams, we had Epi Task Force, Vaccine Task Force, our Data and Analytics Task Force, individuals in our respiratory virus branch, many of which who scrambled very quickly to get us data, not only in a short period of time, but over holidays. So I want to extend my personal thanks to the people represented on this slide to make this presentation happen. Next slide. So then I think, Dr. Lee, as I turn it over to you, I want to pose these questions to ACIP. What does ACIP think about the recommendations for booster doses of the COVID vaccines in adolescents 12 to 15 years of age? And what are the ACIP thoughts around the may recommendation? And then the ACIP thoughts around the should recommendation? Thanks.
Thank you, Dr. Oliver. I really appreciate your going through that complex discussion and rich set of decisions ahead of us. I want to open this up to questions focused on what Dr. Oliver has on this slide, and so would invite our ACIP members to ask questions or provide comment. Ms. McNally.
Thank you. Dr. Oliver, just going back to slide 41, please. Is there anything that you can say to the public right now to allay concerns regarding the potential unknown long-term side effects?
Thanks so much. I do think we can highlight that we've had recommendations for adolescents, this 12-year-old population, since May. We've had extensive post-authorization safety surveillance in this population. We've had millions vaccinated. We did identify, so I even went back earlier today and looked. We had the recommendation for 12 to 15-year-olds mid-May, and the ACIP the ACIP meeting on myocarditis mid-June. So that's how quickly we rapidly identified and brought this to ACIP. The rates for the myocarditis that we've seen have actually been stable really over time. So I think we've identified that quickly. We know and understand that. And then we've been watching for months and have continued to see that VE is high. We know that this is the best tool to prevent COVID-associated disease, hospitalization, and death. So we continue to get more information. We see the continued benefits. We know now that it can prevent hospitalization with MIS-C. And so I think I would just continue to say we're conducting rapid, extensive post-authorization safety that has demonstrated that these vaccines are safe and effective.
Thanks so much, Dr. Oliver. And I understood, I think, from your presentation, the acceptability surrounding the vaccine in general, but is there any specific information regarding the acceptability of a booster in this age group?
Thanks, Ms. McNally. So we tried. I think ultimately, since the information about the potential for boosters was only announced a couple of days before the meeting, we weren't able to get a rapid survey out there. So we'll continue to follow, but we don't have specific information around acceptability. As I mentioned before, if we look back through what we've seen as the booster recommendations have evolved over time, there is a cohort, about a third of the vaccinated, the eligible population, that goes right away. So I think we're anticipating we may see something like that for the 12 to 17-year-old population as well, but we'll continue to follow.
Appreciate the information.
Thank you. Dr. Paling?
All right. Dr. Oliver, I want to say thank you to you and the entire team for pulling all this data together. And one of the things that really struck me was the hospitalization rate. And if there's any chance you could, it was early on when you zoomed in on the children, could we pull that up?
This slide, or you want the next one? Okay, slide 12.
And so what struck me about this slide is that you can see the 0 to 4s are clearly higher, and they're the ones where there is no vaccine recommendation. And then I believe you pointed out that hospitalizations were 11-fold higher among the unvaccinated. So definitely demonstrating how the 16 to 17-year-olds, as they've had increased vaccination, their rates are coming down on hospitalizations. As I'm sitting here thinking about the questions that you ask, we have a hospital that's full, and we have of COVID across all ages, the unvaccinated being far more representative, and we have children waiting in the ED 18 hours and longer just to get into the hospital because we're so full. We also have parents that are asking us, can their children get a booster dose like older children? And so as I'm looking at this and as we're looking at how transmissible this is, I am leaning towards should. Over.
Thank you, Dr. Paling. Dr. Sanchez.
Thank you. As I think about the may or the should, the 16 to 17-year-old is still a may, is it not?
So actually, thank you very much for pointing this out. And I don't want to get ahead, but I think I can say, if you guys decided to go with a may, you could vote on 12 to 15 may. I think if you guys decide to go with should, then the vote would likely be 12 to 17 should, so we can make sure that the 12 to 15-year-old is harmonized with the 16 and 17. So thank you for letting me clarify that. You're right. Right now, 16 and 17 is May. So if you moved to should, we would move the 12 to 17-year-old population together.
Dr. Zimmerman.
Speaking as a vaccine researcher over the decades, the human immune system responds well to boosters. Therefore, personally, I support should. Over.
Thank you. Ms. Bata.
I too support should, but I do want to pontificate a little bit. I am so concerned that the burden of disease prevention is all falling on the vaccinated and them getting the boosters, and that we, as I heard from one of the epidemiologists at WHO, we cannot get through this pandemic through boosting, and yet I understand that we need to be able to use every single tool in our disease prevention book. But I would really like to see much more clear direction to the general population about the other measures to prevent disease spread. I rarely see people masking anymore, especially indoors and gatherings. And to me, that is such an important adjunct to the tool of vaccination. And so I just need to get that out, that we can't put all of the burden on the people that are willing to get vaccinated. And when we only have half of our adolescents vaccinated, that adds more burden as well. But I do lean towards should. Thank you.
Thank you, Ms. Bata. Dr. Kimberlin.
David Kimberlin, this following comments is my own alone. I'm not speaking on behalf of the AAP. I've heard the question raised at prior ACIP meetings and among other experts around the country of what we're really asking of these vaccines. And I think that we need to fundamentally first pose that question again. Are we asking the vaccines to prevent every runny nose? Or are we asking the vaccines to prevent hospitalization and death? And if you look at slide 20, I believe, of Dr. Oliver's slide set, at least, during the Delta period, the vaccine effectiveness was looking really, really good. These vaccines are working in what I would suggest is the only reasonable and possible way that they can. I don't know of any vaccine that can prevent every respiratory infection, symptomatic or mildly symptomatic or asymptomatic. So I would suggest a refocusing on what we want from the vaccine prior to deciding whether boosters would get us there. Thank you.
Thank you. Dr. Maldonado.
Yeah, thank you very much. And again, this is my own personal opinion based on my interactions with my colleagues across the country. I really understand what Dr. Cotton mentioned around who's getting sick and the complexity and the tragic circumstances that we're seeing in the immunocompromised kids. So, but at the same time, we are still seeing a number of children who don't have underlying conditions who are being hospitalized as well, and who are contributing to household transmission and school transmission. So one of the areas I wanted to bring back, and also since Dr. Kimberlin brought back refocusing, which I agree with, and what Ms. Bata said as well, is we really need to start thinking about ways to reboost, no pun intended, our efforts to get people back to the basics. I know we're all tired. We are, our staffing issues are deplorable at this point. We're seeing record numbers of people out of work, and, that may, quote unquote, be expected from a bad cold virus, but but we're also seeing our kids being affected. We have record numbers of cases in kids now, record numbers of hospitalizations of kids, and the deaths are going up. It still is in the top 10 causes of death for children in this country. We can't forget that, and that is a really important area to emphasize. The fact that less than 25% of 5 to 11-year-olds have been vaccinated yet, and that only half of our adolescents are vaccinated at this point, I think is really critical. And obviously, I think a booster is important, but we need to really base that booster on reinforcing the need for vaccinations for others, for masking, distancing, et cetera, because we're seeing the consequences of this whole pandemic. It's not just the vaccine, but it is one tool in getting our kids back to school, getting them back into society. And we're seeing the overflow here, where school districts are now shutting down, teachers are refusing to go back to school, et cetera. So I think overall messaging can be based on vaccines, but we need to broaden that out and make sure that to protect our children in every way we can, we need to really reemphasize the safety that we need to take to keep them protected. And vaccines are one very tangible way to do that, but there are others as well. Thanks.
Thank you. Dr. Long.
Yes, I couldn't agree more with Dr. Kimberlin that this is a hospitalization and death vaccine. Anything else we ask of it is over the top. And although a booster dose may get that kind of antibody for a very short period of time, that may give some protection against symptomatic infection, that will not last. And it will probably give no protection against asymptomatic infection. So I think that we are getting enamored of the Israeli study, for instance, showing that boosts were, a decreased infection rate, and that's not what we're going to be able to accomplish. However, on the other hand, we're right in the midst of this new phase where children are affected. And children are affected in large numbers, and that I think until we get past this peak with Omicron, I'm very much in favor of should boosting, and that this will help us understand over time whether it does, if there will have been any protection against hospitalization and death for those who are otherwise fully vaccinated. I think we have no information that is happening. We do know what the antibody titers look like. I think it will allow us to whack-a-mole for another month or two, but this is not sustainable, and it's not smart to think that we have to continue to boost to prevent infection or mildly symptomatic infection, because it just isn't going to happen unless everybody in the country gets Omicron and we then transition to an endemic, less severe disease. So I'm in favor of should for this age group as the last whack-a-mole.
Thank you, Dr. Long, and appreciate everyone sharing their input on this difficult topic ahead. Dr. Talbot.
I'm going to disagree just for the reasons of the limitations of the current medical care system. I feel like if we say should, that's going to turn many providers into going back, and we really need to move forward. We need to get the other 50% of the 12 to 17-year-olds, and we need to get the other 75% of the 5 to 11-year-olds, and that really should be the main concern. It's nice to have that booster in the 12 to 15-year-old to prevent, illness, but most of them will be safe after 2 vaccines from a severe illness, and that if we spend the time making those may should, we may lose some of our 5 to 11-year-olds. So I really, if we had a really well-funded public health system that had the capacity to do everything, I would say, yeah, should be great. But I really think we need to focus on the 5 to 15-year-olds who aren't vaccinated. Thanks.
Thank you. Dr. Sinayas.
Yes, I also agree with the need to double our efforts to reach the unvaccinated. But given the current state of the surge, I'm also leaning more towards a should than a may. And I do think that the language should align with the older age group, the 16 to 17 years old. But I also have a question about, given the surge that we're having, we are seeing patients in the 12 to 15 age group who've been vaccinated who are now having breakthrough infections. Is there any guidance on the recommendation for boosters for those patients in terms of timing after a recent infection? Or will there be a recommendation?
Dr. Twyman or Dr. Oliver?
Yeah, thanks so much. We don't have, the only recommendation that we have specifically around recent infection is if you are, during the time period that you should be actively kind of quarantining or isolating, please don't go get vaccine then, as we just don't want you to be waiting in line at Walgreens, if you just tested positive that day, because it would potentially, put the vaccinator staff at risk. But otherwise, there's no, specific minimum interval between recent infection and time that you could get a booster dose.
Dr. Hoag?
Thank you, Dr. Lee. This is Michael Hoag with the American Pharmacists Association. This is maybe one of the toughest questions that I think we have faced recently. And I know we've had a lot of really tough questions, but I'm personally struggling deeply with the may versus should. I'm struck particularly by Dr. Kimberlin's comment about what is it we're trying to prevent here, and it's hospitalization and death. We do see breakthrough infections to the previous comment. I think that we have to acknowledge that in the adolescent and adult groups, the majority of these vaccine doses are being given in pharmacies. And you all are probably aware that there is a increasing severe shortage of staff personnel in pharmacies, both of pharmacists and of pharmacy technicians. And the amount of burnout that's happening in those practice sites is pretty significant. I think that when we have limited resources, as Dr. Talbot has said, we have to think about what is reasonable to ask of our limited resources to be able to accomplish. And I think that while in an ideal world where everything is funded the way it should be funded and we have no shortages of healthcare professionals, a should might be okay, but frankly, the hospitalization rate, I realize that every hospitalization is one too many and every death is one too many, and we want to do our best to prevent it. But the hospitalization rate and the death rate among the adolescents in this age group are very, very low compared to the older adult age group that we have made stronger should recommendations for. And so I think, as a result of all of these things, stress on the existing system, the small numbers of people who we are seeing in these age groups that are hospitalized or dying from COVID, I think it's premature to go to a should statement at this point. It could change in the future, and therefore I would support and recommend a may recommendation for this age group.
Thank you. Dr. Lair?
Thank you. I'm surprised to be in favor of the should recommendation because I usually think that we go too much in favor. I strongly support Dr. Long's and Dr. Kimberlin's perspective. Having said that, I see this as a surge that is greater than other surges. I see the number of cases as tremendously higher. And just by the volume of cases, I would see a large number of people ending up in the hospital. and that is what is concerning me. So I would go with Dr. Long's whack-a-mole analogy of let's whack this one down and reevaluate in the future, but I'm in favor of a should recommendation.
Thank you. Dr. Sanchez.
Thank you. I also, I'm torn. But I definitely agree with the colleagues, and that we need to make sure that the message is to prevent serious disease. And I think that that's been a fault from the beginning of the vaccination program. And I think it has, the talk of preventing just a regular infection has contributed to vaccine hesitancy. So I think we have to be clear that that's it. On the other hand, in terms of the may or the should, I become concerned about the should and what does that imply and what does that ultimately say. So is the should going to bring more vaccine mandates? And will it change what we consider to be fully vaccinated individual, which would be down to age 5? But at the same time, my struggle is that I believe in the vaccine. I believe that it has been safe. I believe that we can prevent serious infection. And with this Omicron surge, even though it seems to be less severe and certainly less severe among the vaccinated individuals, this vaccine, the messenger RNA vaccines, do work. And there is some waning of the antibody responses. So I think we can make the overall situation better by actually endorsing a vaccine that I personally believe in. And so I'm really, despite much struggle, and I'm sorry that I'm going on, I ultimately think that we should come out with a more forceful recommendation and go with the should. Thank you.
Thank you, Dr. Sanchez. I'm going to call on Dr. Amanda Cohn for a moment.
Thanks, Dr. Lee. I just wanted to, Dr. Sanchez brought up this issue of whether or not a should versus a may would change potential mandates. And I just want to remind the committee that, the federal government we don't make school mandates. That happens at the state and local level. And so we should really try to keep that not as a consideration in terms of making these decisions. But I also just want to clarify that I think it was yesterday, we updated our guidance around the fully vaccinated to use language that says up to date. May have been today, I'm sorry, I'm getting my days confused. But so we're now using language that says up to date, which allows us to include booster dose recommendations based on time since an individual got vaccinated last, so that word fully vaccinated really just applies to the primary series, and we should really be focusing on making sure that everyone is up to date. Finally, as I very rarely bring my personal opinion into this, but as a parent of 3 kids in these age groups, I just want to say that I do think that understanding the, there's so much burden and stress on everyone, but I do think that there's been a particular challenge in this age group in terms of kids being isolated and having problems with depression and anxiety and challenges when they're sent home from school because they were positive or can't go back to college because they're positive. And so I think all of those sort of unimmeasurable potential impacts of a booster dose, fully recognizing that it may not eliminate transmission, but it may even reduce the potential for a child to be positive or to be infected, could have a larger immeasurable impact on the well-being of these kids.
Thank you, Dr. Cohn. Next, we'll go on to Dr. Cotton.
Thank you.
I'd like to second what Dr. Cohn just said, and I strongly agree with her comments. I would like to speak in favor of a should recommendation. I am seeing many families where there is transmission from children to adults, and in some cases there are devastating outcomes. So I think as much as we can prevent what might be mild to moderate disease in children, but as much as we can decrease disease in families, I really think that that's the way to go. I think that the impact on a child who brought illness into a home and it sometimes results in the death of a parent or a grandparent is absolutely crushing. I'm seeing this clinically, and I think that the more clear we can be in our recommendations, it's really, really helpful to those of us in the clinical trenches. Also again, to protect the immunocompromised patients, protecting children who are really one of the major ways that people are being exposed these days will really help prevent disease in immunocompromised patients as well. So I'd like to speak in favor of should. Thank you. Thank you, Dr. Cotton. Dr. Brooks?
Yes. First of all, excellent meeting. I think it is really important that we're having these deliberations, these discussions, because we are all hearing this in real time. So this information coming in is actually affecting how we are thinking and how we are theoretically going to vote. I would speak in favor of should. Now, we're looking at this ultimately from benefit-risk ratio. And it's interesting because, to me, the benefits are unknown, but the risks are known. I mean, we don't know that if people get boosted, will they help them with the next variant? But it probably will help in some way. So it's a good unknown. School attendance, we do know that it will likely affect that. That's important. Transmission, we don't know, but we believe that it may help with reduced transmission, both to other children and to adults. We do know that it will reduce hospitalizations and death, though to what degree, it's not that high. The death and hospitalization rate is not that high in this age group. But looking at, like slide 51 said, the primary goal is the reduction of hospitalization, of severe disease. So when people are talking about what are we looking at, the work group said severe disease. So that is what we are looking at. And then one other thing, maybe there are people that are immunosuppressed that don't even know it that are going to get this booster. And so it will protect those that even have unknown conditions. Now, the risk we know is myocarditis, but we didn't even discuss in this particular deliberation that if you get COVID, you have more of a chance of getting a severe myocarditis. So I think that is mitigated. So lastly, this is one tool in our toolbox, and I think that we should, if it's a hammer, we should hit that nail hard. And so I am in favor of a should recommendation.
Thank you, Dr. Brooks. Dr. Paling?
I would like to follow and agree with my colleagues about the should. I think we need to highlight that children are not okay. Our hospitals are full, and it is true that children are hospitalized at a less frequent rate than adults, but it is COVID is overwhelming our hospitals and our children's hospitals. And as Dr. Donato emphasized, COVID-19 is a top 10 cause of death among children, and so this is not benign. As Dr. Brooks just mentioned, children with COVID, we are seeing myocarditis and severe myocarditis, and we're very worried about the MISC to come. The other thing is, I too am seeing children who have lost parents. And so when they are quarantined, this creates undue stress and hardship on them and their families. And missing school is a big deal. And so I think this is a tool we need to use and help our children through this pandemic. Thank you.
Thank you. Dr. Talbot?
I'm a little worried about how we're talking about the kids that are in the hospital. And I need someone who is familiar with the epi to explain this to me. Are the kids that are being hospitalized for COVID vaccinated or unvaccinated? Because if they are vaccinated, that makes a big difference in the use of the boosters. It should be a should at that point. But if you're telling me the kids that are being hospitalized are unvaccinated, it means we need to spend our days and nights vaccinating those that are unvaccinated. So if someone could just answer that question, it'd be great.
Hey, Dr. Talbot, this is Dr. Oliver. I mean, I think we can definitely, I think there are vaccinated kids who are in the hospital. We know that the highest risk is in the unvaccinated. So if we go, I can't remember the exact slide.
It was a beautiful slide that showed it was the
slide 14. Slide 14. So, I mean, it's not zero, it's low among the fully vaccinated 12 to 17-year-olds. So it's not zero, but definitely the highest risk is the unvaccinated and fully.
So I think in response, Dr. Oliver, I think what I'm trying to say, and sorry to cut you off, is that this booster will not be a hammer. This booster is gonna get the nail in a millimeter, and then there's 20 millimeters that need to go in that this hammer's not gonna work on. And so I guess that's my thought, that if we divert our public health from the unvaccinated to the vaccinated, we are not going to make a big impact. Boosters are incredibly important, but they won't solve this problem of the crowded hospitals. That's going to be the unvaccinated. Thanks.
Thank you. I'm actually going to jump in. I recognize there are many hands raised, and I'm really grateful that everyone is, sharing their opinions. I wanted to just start out by, I agree with nearly all of the comments that my colleagues have mentioned, but I did want to state a different opinion, which is that I actually think we are trying to prevent infections and not just serious disease and hospitalization. This is not dissimilar to the reasons we also continue to use tools like masking and testing. We are trying to reduce the risk of infection to protect ourselves and others. I also think that we have burdened an entire generation of children, whether or not they're infected, with the impact of COVID. And I certainly think that infection and transmission are impacting our ability for individuals to function. So keeping our schools open, keeping hospitals open, keeping businesses open, keeping communities open, all of this to me is critical. I see vaccines as not the only solution, but one part of the broader public health conversation we need to continue to have around vaccines, masking, testing, et cetera, for us to be able to manage through this pandemic. So I just wanted to just make sure we are, at least that I got my opinion in, that I don't think it's just about hospitalizations and death. I truly think it's about the entire picture of our kids in terms of not just their physical health, but their mental health, their social emotional functioning, their academic development, et cetera. And I also truly believe we have not yet addressed the long-term impact of COVID infection in children. I think we haven't even scratched the surface of what we're going to see. And so, I would say that we continue to need more data for sure. And I'm just hopeful that others will also perhaps consider prevention of infection a worthy goal. I want to call on our ACIP members, and I have our liaisons who also want to weigh in. We want to make sure we get to everyone. So I think I have Dr. Sanchez, are you next?
I did have another comment, but
okay, go ahead.
Although and I had another comment, but I'll just make that we all want to prevent infection, but I think the current vaccine is really showing us that more for serious infections. But I think in this should versus may, and I understand the problems with implementation of a booster and all of that, but I do think that we need to do what is best for those families and children who want to be vaccinated and who do want to be as protected as possible. So I think that that a should will allow that to happen as well, and also with with a stronger recommendation. I mean, there may be implementation issues that heard, but I think that that we need to do what is best. And then I had a question, and maybe not now it's not the best time, but I'm still a little bit. I was confused a little bit by the up-to-date change, and that could be done later. But I was a little bit confused about the current statement on up-to-date versus fully vaccinated.
Thank you. I don't know if Dr. Cohen or somebody from CDC wants to respond, or if I can take a couple more questions first and then come back to our CDC colleagues in case there's something that they can share or show.
Yeah, take a couple more questions.
Okay, thank you. Let's go to Dr. Peeling.
Yes, thank you. I greatly appreciate this robust discussion. And as I'm thinking about it, we have a similar, I'm appreciative of the slide that's on here showing the difference in unvaccinated versus vaccinated hospitalizations. This is similar to what we see in adults, and we have a should recommendation for adults. I believe that having the same recommendation across the age groups is the way to go and improve clarity of communication. Thank you.
Thank you, Dr. Peeling. Dr. Daly.
Yeah, thanks so much. I'm going to make 3 comments, and they're a little bit disparate just because I've been trying sort of listening in and thinking hard about what's been said so far. So actually, first, I'm going to go way back to a comment that Ms. McNally made about what's known about long-term safety. It's a great question, and this in some ways is directed to parents of unvaccinated kids, but I think, decades of experience with vaccines has shown that for the most part, if they cause side effects, those are in the short term. But I would sort of keep in mind that when we met in August of 2021 to review the BLA for Pfizer, at that point we had 12 months of safety data from the individuals or maybe not exactly 12 months, but nearly 12 months of safety data. And we vaccinated several 100 million adults since now. So we have more data that's reassuring about long-term safety than we would typically have for any other routine childhood vaccination. So we never know everything about long-term safety, but what we know to date is really reassuring, and we have longer-term follow-up because, those clinical trials were conducted in the summer of 2020, and then we met in August of 2021 for the licensure for Pfizer. So that provides reassurance to me. In terms of should versus may, I certainly I would vote in favor of either, although I've been thinking about whether this really perhaps may have been a 3-dose series all along, and if that is the case, then I would be in favor of a should recommendation. I think 2 doses spaced very closely together was dictated by the pace of the pandemic, and then the observation that immunity was waning came later, and we had to do that at the time. But it may have been that this was a vaccine that all along needed a booster to achieve the best vaccine effectiveness we could achieve. So a third point is that I don't think a should recommendation in 12 to 17-year-olds is going to take away from our public health focus on vaccinating the unvaccinated. I think the hard thing is that everybody who is eligible, I think, could have received a vaccine by now, and so then that group is going to be challenging to convince, but I think we need to do everything we can. But I don't think should recommendation for 12 to 17-year-olds really takes away from that. And then my final point is that during the work group yesterday, we heard from one of the work group members who said, vaccinating 12 to 17-year-olds with a booster, if it prevents their lives from being entirely disrupted by testing positive, where they can't go to school and they can't be around their friends, and they'll be very isolated in the basement of their house. That is, in that individual's view, worth it for boosters. And so we're mainly trying to prevent the most important goal is preventing hospitalization and death, but I feel like positive testing in 12 or mildly symptomatic disease in 12 to 17-year-olds is incredibly disruptive, and they've suffered greatly from the pandemic. Those are my comments. Thank you.
Thank you, Dr. Daly. I'm going to do a quick check-in. Does anyone from CDC want to comment, or can I go through the liaisons next? I don't hear anything. I'm going to go through the liaisons really quick. Oh, okay, go ahead.
Yeah, I mean, I can just quickly explain to Dr. Sanchez the up-to-date shift. So we're shifting to language that tells people, instead of we want people to be fully vaccinated, we want people to be up-to-date on their vaccines. So fully vaccinated implies the original 2-dose series of an mRNA vaccine or a 1 dose of a J&J, whereas staying up-to-date means that if you are eligible for a booster dose, or if you're moderately or severely immunocompromised, you should have additional doses. And so we're going to be over the course of yesterday and through the next several days, we'll be rolling out additional communications around this issue to start to get the community sort of to shift their thinking to encourage people to be up to date rather than fully vaccinated, since up to date is different depending on who you are.
Thank you. Okay, we'll go. I'm actually going to pause and ask Dr. Oliver if, given the committee's discussion so far, I think we should ask you to put up a vote that includes the language of should for 12 to 17. If you can change that 15 to a 17. That would be terrific when you get to the vote. And in the meantime, I'm going to ask for our liaisons to comment. Dr. Zahn.
Thank you, Dr. Lee. A couple of comments just from a local public health standpoint. Certainly, should recommendations are much easier to understand, to communicate, and implement than may. It's not an absolute reason why you make a decision, but it certainly makes the communication a great deal simpler. In terms of reacting to Omicron, a couple of comments. I think Dr. Daly is exactly right that certainly, any new recommendation is a potential stress, but if the ACIP thinks that this group should receive the vaccine, then we use the resources we can as well as we can to respond. I think that generally speaking, we're really in a testing capacity shortage right now as a country, right? More than an ability to immunize people or vaccination capacity shortage. And so if it's the right thing to do, I think public health responds. I would say that for Omicron, the bigger concern is Omicron's in a hurry in an awful lot of communities. And so these are not waves in other countries or in what we're seeing here that we think are going to be lasting months. And so I wouldn't put too much emphasis on saying we're going to get people boosted to get them through Omicron. I think you should more think in terms of what is the utility of having this population boosted, anticipating that there will be virus, Omicron and other viruses, new variants around in the future. And I do think that it's been said a couple of times, but can't underscore enough, the disruption of COVID in general to schools, but Omicron in particular to the school situation is a very significant issue. This has been going on for a couple of years. We've got to figure out ways to keep our kids in school. And so any measures that we have that will make our schools safer, make it easier for our schools to stay open during this and current surges is well worth considering. Thank you.
Thank you. Ms. Stinchfield.
Thank you, Dr. Lee. Patsy Stinchfield, National Association of Pediatric Nurse Practitioners. I support the should for much of this wonderful conversation, especially your comments, Dr. Lee and Dr. Cotton. So individual protection and societal. Secondly, how do we vaccinate the unvaccinated? I really think in this age group, we just have to get it into standard work like we do other vaccines for people entering schools and universities and make it an entry requirement. And I don't think it's too early to start working on those things even for next fall. And I think as one of our public commenters said, engaging school nurses early and working with education boards and legislators, those conversations should be happening now. And then last, I shared Kathy Palin's concern about the slide with the 0 to 4 year old hospitalizations being so high, and that age group being unprotected. That's probably the number one question that I get from parents is when. And so when the time is right at this meeting, before maybe after the vote, Dr. Lee, if somebody could just give the public a quick update on that timeline, that would be wonderful. Thanks everybody for your dedication here.
Thank you. Dr. Rockwell.
Thank you, Dr. Lee. I'm Pamela Rockwell, American Academy of Family Physicians Liaison. So I just wanted to speak as a family physician, as my AAFP representative, that I support a should recommendation for several reasons. One is to keep the CDC recommendations clear, concise for physicians and other vaccine providers, as has been stated. I am regularly surprised by anecdotal, misinformed guidance my patients have received from other healthcare professionals in my community. Two, in addressing the current state of our compromised and overburdened healthcare force, as we currently see, as another previous speaker spoke about, a should recommendation may result in fewer infections, as Dr. Lee and Patty Lynchfield just stated, result in fewer hospitalizations of both the vaccine recipients and their family members, and therefore a should recommendation may actually help reduce the burden on our healthcare force in a short amount of time. And lastly, in addressing those who have not yet been vaccinated, with plenty of opportunity to do so at this point, and much frustration from those of us who offer vaccinations, I agree with the previous speaker that our public health efforts will not be compromised by this should recommendation, as I don't think it will take away from any efforts to vaccinate the unvaccinated. I believe we need to explore other and different efforts to exchange the acceptance of vaccination for the current unvaccinated population. Thank you.
Thank you. Dr. Duchin?
Thank you. Jeff Duchin, Infectious Diseases Society of America. A should recommendation clearly has advantages in the context of simplicity, clarity, and consistency with other guidance. And I think that the discussion indicates that the ACIP voting members are favoring that. I do want to say, though, that if there were to be a May recommendation, it would need to be very explicit in order to give the public and our healthcare providers and our public health vaccine administration program the guidance about under which circumstances a child who may get it should get it. I mean, how would we make those decisions? That would need to be part of a May recommendation. I think that this discussion clearly does not, or today's decision is not informed by the amount of data that any of us would like. And it's an example of real world, real time, and real tough pandemic decision making. And I commend the ACIP members for the excellent discussion and the thoughtful deliberation. I do think that we need to get back to what I believe Dr. Kimberlin mentioned at some point, which is to explicitly define the goals of our national COVID-19 vaccination program with respect to prevention of infection versus serious disease. And I anticipate that can happen once we're out of the acute crisis stage of these recurrent surge waves. But I think that should be an explicit topic when possible. Thank you.
Thank you. Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I've heard from a lot of people that they're frustrated that the language coming from the CDC seems to change all the time on what the recommendations are. So I think that when this comes out, we need to continue to promote that as the virus changes, we have to change with what our recommendations are. And I do think that we need to have a conversation about what being fully vaccinated means, because there is some confusion in the public still about if you've had one J&J, is a booster making you fully vaccinated, and is 3 vaccines going to make you fully vaccinated? So that, I think we need to get a very strong message going out, what is being fully vaccinated. Thank you.
Thank you. Ms. Arthur?
Hello, Phyllis Arthur for Bio.
I actually just wanted to talk about something that Dr. Cotton talked about. I think there's a lot of interest in better understanding the various symptoms and effects of COVID infection on young people. I think there's not so much clarity. I think people think it's milder than it is, and this group has a good understanding of that. So maybe an MMWR or some kind of publication that very clearly captures the various impacts of COVID itself on children in the various age groups. I think that would help also to make the case for why vaccine is so important in the unvaccinated group there. There may be this misconception that it's generally always asymptomatic or mild disease, and there have been circumstances with some of these more important side effects that are showing up for this age group that could help parents make a better informed decision.
Thank you. And Dr. Whitley-Williams.
Thank you. I was going to make some of the comments that have already been said, so I will not review those, but certainly recommending boosters in the 12 to 17-year age group is just one step in stemming the tide of this pandemic. And I do agree with Dr. Talbot that certainly the focus, one of the other steps that need to be taken is certainly to encourage people who are unvaccinated to become vaccinated. And having been on the pediatric ID service within the last 2 to 3 weeks, we are being overwhelmed, as has been demonstrated by children who are unvaccinated and from families who are unvaccinated, including mothers and newborns. The newborns have not been terribly sick, but we are starting to see that phenomenon. The second comment I had was in light of the noted racial and ethnic disparities in vaccine coverage and parental intent. Just want to remind the committee that there are still existent social barriers that do exist in communities of color. That is not an excuse, but it is a reality of the situation. However, I can assure you that the National Medical Association continues to educate its membership, primarily who are African American physicians, and provide care for persons in communities of color, as well as to educate the public and persons in our communities of color as well. Thank you.
Thank you so much. And Dr. Kim, you have the last word before we move to vote.
Well, thank you very much. I'm David Kim, OIDC. I would like to see if we can consider the perspective of the folks at the user end, that is the patients and the public. I'd like to ask, what is our message to the public, and what is our message to the parents of 12 to 15-year-olds and the 16 and 17-year-olds who are on the fence about the primary series or the booster series? As Dr. Daly noted earlier, we're basically at a 3-dose vaccination series, primary series. As such, echoing Carol Hayes and Dr. Duchin has said earlier, the committee has an opportunity and perhaps even an obligation to streamline and simplify and make concise its recommendations, strong recommendations that we're promoting the use of vaccines to control this pandemic and get the message out to the folks who are currently not vaccinated, and to ensure that we have a better chance of immunizing the community so that we can get a better handle on this pandemic. So I would just like to point out that we should make a strong, concise recommendation, and I do believe that that consistent use of should is the way to go. Thank you. Back to you, Dr. Lee.
Thank you so much. And I just want to highlight that what you said was that our recommendations are only the first step of this process, and that a lot rests with implementation and communication to ensure that there is, access, acceptability, and equity was mentioned. And we are extremely grateful to our liaison partners around the virtual table who have clearly supported the implementation efforts, recognizing how difficult it has been in this dynamic pandemic and the need to continually reevaluate, but appreciate the partnership and the collegiality. So now let's move to the vote. I'm going to ask Dr. Oliver to read the vote that is listed on the slide here. Dr. Oliver?
Thank you so much. The proposed language for the vote right now is a single Pfizer-BioNTech COVID-19 vaccine booster dose is recommended for persons aged 12 to 17 years of age, at least 5 months after the primary series under FDA's emergency use authorization.
Thank you. And actually, I see Dr. Alt has kindly put on his camera. I'm going to ask our other members to put on the camera and ask if any of our voting members wish to make a motion. I see Dr. Paling's hand was raised. Did you have a question or did you wish to make a motion?
I wish to make a motion. I wish to make a motion to accept the wording as is. Thank you.
Thank you. We have a motion on the table. Would anyone like to second the motion? Dr. Alt?
I will second the motion.
Thank you. It's been moved and seconded that we adopt the recommendation language presented here on this slide and read by Dr. Oliver. Are there any additional questions or concerns the committee would like to discuss before the vote? Okay, thank you. And I recognize that perhaps not everyone can get their camera on, but we appreciate your presence. And for those of you who have your cameras on, thank you for joining. We'll go ahead and start with our let's start with actually Dr. Chen.
Yes.
Oh, and sorry, apologies. You should state your name, conflict of interest, and then your vote.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Daly.
Matt Daly, no conflicts, yes.
Thank you. Dr. Lair.
Amy Lair, no conflicts, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Dr. Paling?
Kathy Paling, no conflicts, yes.
Thank you. Dr. Talbot?
Dr. Talbot, no conflicts, no.
Okay, thank you. Dr. Alt?
An Alt, no conflicts, yes.
Thank you. Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Thank you. Ms. McNally?
McNally, no conflicts, yes.
Thank you. Dr. Saneas?
Sybil Saneas, no conflict, yes.
Thank you. Ms. Bata?
Lynn Bata, no conflicts, yes.
Thank you. Dr. Sanchez?
Sanchez, no conflict, yes.
Thank you. Dr. Cotton?
Camille Cotton, no conflicts, yes.
Thank you. And Grace Lee, no conflicts, yes. So the motion passes as written, and I believe it is 13 yeses and 1 no. And with that, I'd like to thank our committee members for your time and for this robust discussion. I did want to offer an opportunity if anyone would like to make an additional comment about your vote, if you would like to raise your hand. Dr. Talbot.
So I wanted to be said, I am just fine with kids getting a booster. This is not me against all boosters. I just really want the U.S. to move forward with vaccinating all kids so that all kids can go back to a normal life. And I don't think it's fair for the 12 to 17-year-olds who have been vaccinated to risk myocarditis again for an unknown benefit because their colleagues won't get vaccinated. And so I think it's incredibly important that we continue to follow the safety of these vaccines, the immediate risk of the myocarditis after the third vaccine, and the incremental benefit of a third vaccine in these kids. If you are a parent out there who has not yet vaccinated your child because you have questions, please talk to a healthcare provider and do not use social media. It is so easy to take things out of context and to try to get new Twitter followers, and none of that is going to help you protect your child. Please talk to their pediatrician. Please talk to a healthcare provider, and let us know what questions that you have that we can answer. Thank you.
Thank you. Dr. Cotton.
I'm glad to see that we voted in favor of this. I would like to suggest that at upcoming ACIP meetings that we strongly consider advancing the time frame for booster doses for immunocompromised patients. I just heard that at my own hospital, of all transplant patients, kidney transplant patients with COVID-19, 25% have happened in the past 2 weeks. We are in a state of crisis. This is an emergency. We really need to act soon. We can't wait. This is a matter of major emergency and crisis. Thank you.
Thank you, Dr. Cotton. Dr. Long.
Yes, I just want to say I'm not thinking of children taking the risk of a booster dose to protect themselves because others haven't taken the risk of their primary dose. First of all, we didn't talk about it very much, but I have very low concern for myocarditis, vaccine-related, after booster dose. It's far enough out. The antibody levels are not that super spike that occurs a month out. And I think the data have shown that it's much lower risk after a booster dose. So I didn't consider in my deliberation that there were any trade-offs here of anybody being a soldier when others weren't, but rather the potential benefit for the children, especially in maintaining the life that they should be able to have, that booster doses in the short run might affect. Thanks.
Thank you. Ms. McNally.
I really want to thank the CDC for all the work that went into today's meeting and to my colleagues for a very robust discussion. I have 2 children in this age group who I will be taking to get boosted, and I really want to encourage all parents with questions to get answers to their specific questions about this vaccine because it is so important. Thank you.
Thank you. I do not see any additional hands raised. With that, I think what I'd like to do is ask Dr. Wharton if there's any additional business or if anyone has any objections to adjourning today's meeting.
No, we can close.
Oh, Dr. Lee, this is Patsy again. Is someone able to answer my question about the younger age group timeline?
Oh, thank you, Ms. Finchfield. I don't know if we have a colleague from FDA who might be able to comment. Dr. Fink, are you still on?
Yeah, I'm here.
Thank you.
Clearly, the reported increases in pediatric hospitalizations overall, including children under the age of 5, are concerning. As we all heard from the press release issued by Pfizer, they have an ongoing study of primary series vaccination in children 6 months to 5 years of age, and they did not meet the immunobridging success criteria in one of their analyses. And so we are evaluating what options are possible for moving forward with evaluating the vaccine in this age group in order to figure out how to best make available a safe and effective vaccine as quickly as possible. And I don't know if anyone from Pfizer wants to comment either.
Yeah, this is Alejandra Goodman, just checking that you can hear me.
Can.
Okay. Hi, everybody. I am in the Vaccine Clinical Research and Development Group at Pfizer, and I will give you a little bit of a high timeline, but I would like to start by stating that, in view of all the discussions that we had today and the disproportionate burden of disease and hospitalization in children, Pfizer has as a big priority to develop to come up with a vaccine and the right number of doses that is safe and effective. And as Dr. Singh just mentioned, we did not meet the non-inferiority criteria for the 2 to 5-year-olds. The non-inferiority criteria was met for the younger age group, which is 6 months to 2 years of age. I do want to say that through a meeting in late December with the DMC, the vaccine is safe. And so this is an immunological criteria that has not met. In view of that and all the information that you discussed today and the data that is becoming available about the effectiveness of 3 doses of the vaccine for those who are 16 and older, and as of today, those who are going to be vaccinated who are 12 and older, And the laboratory data that we have also for the Delta and other variants, it is becoming very clear that this might be a 3-dose vaccine. And so the study is being amended to give a 3rd dose to everybody who's less than 5, at least 8 weeks after the last vaccination. And we're also going to be providing a 3rd dose to those who are 5 to 12, at least 6 months after the last vaccination. And at the present time, we are looking to have the data for the less than 5, the 3-dose data, the immunogenicity data by either end of March, beginning of April. So late Q1 of this year, so a few months from now.
Thank you very much, Dr. Gertman. And with that, I'd like to close the meeting and again express our sincere gratitude to the ACIP members, ex officio members, liaisons, CDC staff, and other federal collaborators for your time, your knowledge, and your commitment to the process and your willingness to have a challenging and respectful discussion today. And with that, I will say the ACIP meeting is now adjourned. Thank you, everyone, and I'm sure we'll be talking again soon. Take care.